without further delay, I will start the presentation. So I will be the patient for today as well. ከዛ ያው እንግዲህ እግዚአብሔር ሲፈቅድ ወደፊት እናንተም ፓርቲሲፔት እያደረጋችሁ ስትመጡ ደን I will have other people እና ቁጭ ብዬ ተመልካች ሆናለሁ ማለት ነው። ኤክሰለንት እና በጣም ደስ ብሎኛል በእውነት ተመልሳችሁ ስለመጣችሁላችሁ። I respect you guys. So, this is episode number 2. We have an interesting case actually, very interesting case. In this process, actually, I'm also learning, by the way. So like we did last time, for those of you who are new, what we are going to do is I'll just give you the chief complaint. And based on the chief complaint, I expect you guys to forward your differential diagnosis. And, as we go along, we'll narrow it down, okay? So the chief complaint, I am the patient. And I came with a progressive shortness of breath and bilateral leg swelling of 2 weeks duration. Progressively worsening, I'm sorry, I should say progressively worsening shortness of breath and bilateral leg swelling of 2 weeks duration. And I am presenting to, we can say, to Gondar Hospital. For today, I said Black Line. I'll change it next time. Okay, I'm sorry. I'm obsessed with Black Line. So give me differential diagnoses now.
Congestive heart failure.
Huh?
Congestive heart failure.
Congestive heart failure. Yeah, I should have told you maybe the age of the patient. That's very important. I am, at least let me tell you, I'm a 35-year-old female patient. Came with progressively worsening shortness of breath and bilateral leg swelling of 2 weeks duration. Now tell me the differential diagnosis based on this information. Congestive heart failure secondary to what? Because that's very important. It could be secondary congestive heart failure, but due to what? Because people wouldn't develop, congestive failure for no reason. So you have to think in terms of possibilityology for the congestive heart failure. So can you give me some causes of it, some possible causes of congestive heart failure in this age group?
Dilated cardiomyopathy.
Dilated cardiomyopathy. That's possible. What else?
ቻት ቦክሱ ላይ ያሉትንም ላንብብል።
አንብብልኝ፣ አንተ አንብብልኝ ስለማይታየኝ ነው።
Okay, congestive heart failure secondary to chronic rheumatic valvular heart disease.
Chronic rheumatic heart disease or valvular heart disease.
Okay, what was the age የሚል ጥያቄ ተነስቷል።
35 years old. 35 years old female patient, progressively worsening shortness of breath, bilateral lower extremity swelling over the past 2 weeks.
Okay. ሌላ differential pulmonary embolism.
PE. Okay.
Secondary to
by the way, why PE? Why are you thinking of PE? Can you speak up? I mean, let's make it interesting. So he said congestive heart failure. Why congestive heart failure, my friend? Whoever has said congestive heart failure, can you tell us the reason why you are thinking of congestive heart failure at this stage?
So she has a progressive dyspnea and also bilateral leg swelling.
Okay, so both are possible, right? So a patient with heart failure can have progressively worsening shortness of breath, bilateral lower extremity edema. Both can be explained by congestive heart failure, so that's valid differential diagnosis. What about PE? And Zex and Betty, I will highlight on what you have said right now. If I forget, let me know once I finish mentioning differentials, okay? I will highlight what you commented last week. Go ahead, PE. Why PE? Whoever has suggested PE, please speak up if you can, or if you cannot talk, just text, just like you did before on the chat box, and Brooke can read it to me.
So then ሁለት ዲፈረንሻሎች መጥተዋል።
እሺ ጨምርልኝ። እስከዛ አስብበት። ፒ ያልክ ሰው አለቅ አንላቀቅም። ኦኬ
አንደኛው congestive heart failure secondary to hypertrophic.
Okay, cardiomyopathy, right? You can say cardiomyopathy in general, and cardiomyopathy could be dilated dilative cardiomyopathy. And what did you say again? Hypertrophic?
Yes.
Hypertrophic cardiomyopathy. Huh? Restrictive. Restrictive cardiomyopathy. All these are a possibility. Okay. And the other is, you said chronic rheumatic heart disease. What else could it be? She's
Nephrotic
35
syndrome.
years old. Okay. On that line, chronic rheumatic heart disease. Lela valvular etiology. Do you know any other etiologies can result in valvular heart disease? Which can happen in this age group? Hmm? Huh? Minalk? SLE? Oh, SLE involving the valves, that's a possibility, though it's a little bit remote possibility. I'll think about it. I'll write it down. But I started writing something, mitral valve. Telling you. Mitral valve prolapse is also a possibility with severe enough. It can result in heart failure eventually. Okay. Whoever has said PE or the person who suggested didn't want to say, do you guys agree with PE being included in this differential diagnosis based on the chief complaint, age, sex? Or you want to
Maybe
keep
not
it in? Huh?
because PE maybe if it was a unilateral lecture, it could have been a possibility, but also the progressive nature of the shortness of breath also is against PE.
Yes. Thank you so much. So it's less likely. We will keep it as a differential diagnosis, but most probably slow down. Like you said, unless this patient has bilateral significant lower extremity DVT, eventually resulting in PE, most of the time we expect unilateral leg enlargement or leg swelling. And on top of that, the presenting complaint is not going to be a progressive illness, right? So if it is PE, it's going to be sudden, right? It's an acute problem. So somebody who is apparently okay comes with a sudden onset of shortness of breath, maybe associated chest pain. So P is less likely, it's less likely to explain bilateral leg swelling. It's less likely to explain the 2 weeks progressive shortness of breath unless we are dealing with something subacute or chronic pulmonary thromboembolism. Sometimes, the clot can stay there and patients may develop, pulmonary hypertension because of long-standing persistent pulmonary thromboembolism, chronic thromboembolism, but the presentation is not going to be similar to this patient. So PE is going to be less likely in this particular patient, right? So, okay, give me another differential diagnosis. You said what? Nephrotic syndrome, okay?
Constrictive pericarditis.
Oh, shit. Okay, so probably right there, let me add constrictive pericarditis. Constrictive pericarditis due to what?
Disseminated TB.
Due to TB pericarditis.
Yeah, most probably secondary to TB in our setup, right? But
Yes.
anything can result in that one. What other cause of constrictive pericarditis do you know? Other causes of constrictive pericarditis. TB is really very common. This lady can have, like you said, disseminated TB involving the pericardium, heals with fibrosis, develops constrictive pericarditis. It could also be a result of what? Come on, guys. It's not common in our setup in Ethiopia, but this lady, if I give you a history of lymphoma when she was 10 years old or when she was 20 years old.
Will be due to radiation.
Yeah, radiation. By the way, if I am an examiner, when I ask a question, if a student gives me a complete answer without me stimulating the cortex, then that person gets the full credit. But if I tell you something, a hint, if I tell you here and there, and you answer it, of course you get some credit because you gave me the answer at the end of the day, but it didn't come out of you, right? So, and you are not going to impress me 100%, you know what I mean? So try to think about causes, constrictive pericarditis, TB, infection. So you can categorize as infectious causes. So it could be tuberculosis, or any bacterial infection which has resulted in chronic inflammation can give you, constrictive pericarditis. The other thing is radiation related, mediastinal radiation. So this lady, if she was treated for lymphoma, mediastinal lymphoma, or if she has been treated for, what can she be treated with radiation? What pathology? Common in females, because they have two important organs here. Guys, speak up. What kind of cancer?
Breast cancer.
Breast cancer. So, cancer treatment, it could be breast cancer, it could be lymphoma, radiation. What other cause of constrictive pericarditis do you know?
Uremia?
Huh?
Uremic pericarditis.
Uremia. It's a little bit remote possibility, extremely rare. Common things are common. So think of common things. Easy, straightforward. If I tell you this lady had congenital heart disease, which has been repaired a couple of years ago, could that be a very good reason why she is developing constrictive pericarditis? Surgery, right? Post-surgical. Because if somebody had mediastinal surgery or a patient had previous cardiac surgery, then, they tend to develop constrictive pericarditis. So any surgery, radiation, TB. So knowing this is very important, because when you are asking questions during HPI, during personal history, social history, family history, past medical history, and past surgical history, you have to include, questions which would help you either exclude or include these potential differential diagnoses. That's why you have to really be thorough when you are thinking of differential diagnosis. We are thinking a lot here, okay? Okay, PE, nephrotic. PE, I am going to take it down. I will do it later on. Let's finish first. Nephrotic syndrome. Why are you considering nephrotic syndrome? And like I always say, if you speak loud, if you speak fast, if you participate, our discussion would go by fast. We are not killing time, so that we can cover a lot of topics. You wouldn't be really bored and things like that. So try to participate as fast as you can, okay? And there is no penalty here. In fact, you will learn a lot. Those who are engaging will learn a lot. And there is that, prize going on, by the way. We are taking notes, Zex, myself, and the rest of the team. We will surprise you one day. Maybe, we'll give you a couple of $100 for a telephone card or something like that. There will be something, or access to question banks, access to textbooks and things like that. So participate. በማባበያ እንኳን ብትናገሩ ብዬ ነው፣ በእጅ መንሻ። Why nephrotic syndrome, guys? You know the answer. I am sure you know the answer. Why nephrotic syndrome? Can it explain the presenting complaint? Can it happen in a 35-year-old female patient? That is the question, in other words. አትፍሩ። Try. ዜክስ አለ?
አሎ ዶክ።
ኦኬ፣ አንተም ተናገር እንግዲህ። በቃ ያለህኝ አንተን የመጨረሻ አማራጭ ምን ላድርግ? Why nephrotic syndrome? Can nephrotic syndrome be considered here? Or shall we take it down or exclude it?
We can consider nephrotic syndrome because the patient has congestion.
Yeah, the patient is coming. Yeah, go ahead.
Since renal congestion usually starts from the eyes, even though that's not a typical form of congestion we're seeing in this patient, but since it's the dependent type and respiratory affect you can definitely consider nephrotic syndrome.
Yeah, definitely. Nephrotic syndrome patients, they will have remarkable edema involving each and every possible part of the body, including the lungs. So this patient, who knows, may have pulmonary congestion. She may have bilateral, pleural effusion. She might have, ascites pushing the diaphragm up. And that might be the reason why this patient is experiencing progressively worsening shortness of breath. And bilateral leg edema can be can be explained by anasarca due to nephrotic syndrome, so it's a possibility. So nephrotic syndrome can be a potential differential diagnosis here. We'll keep it for some time. We'll see if it is going to stay there or not. Okay, other differential diagnosis?
Disseminated TB to the pleura, pericardium membrane.
Disseminated TBC, okay, disseminated TB. Just acute disseminated TB, right? That is a chronic manifestation, by the way. So disseminated TB in the acute phase wouldn't result in constrictive pericarditis. The inflammation in constrictive pericarditis is a sequelae of TB. You know, most probably patients with constrictive pericarditis may not have an active TB going on. Okay, that you should know. So disseminated tuberculosis may explain progressively worsening of shortness of breath. The only thing it cannot explain is what? So not only disseminated TB, even like pulmonary tuberculosis can explain progressively worsening shortness of breath. Please mute, guys, when you join. Mute, guys. Gazacho, mute your... Gazacho Abata. Yeah, thank you so much, my dear. So disseminated TB by Honen, if a patient has remarkable involvement of the lungs due to an active tuberculosis, he or she actually, it's a she, so she may be presenting with progressive worsening of shortness of breath. The only thing it cannot explain is what? Huh?
The swelling.
Yeah, the swelling. So, I mean, you know, it may not necessarily explain the bilateral leg swelling, but for just for the sake of the shortness of breath, we can keep it disseminated TB or pulmonary TB.
Okay, Lila differential.
Uh-huh.
Secondary, CHF secondary to endocarditis.
CHF with endocarditis. Infective endocarditis, yes. And this is common in what kind of patients?
Post-surgical.
Yeah, any surgical intervention or any other person who is high risk for developing infective endocarditis and eventual congestive heart failure. Common things are common, guys.
Yeah, it's already
Prosthetic
mentioned.
valves.
Huh?
Prosthetic
Men?
valve የሚጠቀሙ prosthetic valves የሚጠቀሙ
Yeah, አላወቅንም አሁን we don't know, we are not sure whether there is a prosthetic valve in place or not, but you know, common things are common. Let me tell you, this lady didn't have any procedure or surgery in the past. So which group of patients are prone to develop infective endocarditis with to begin with, there must be some sort of valve abnormality, right? There should be some structural valve abnormality to be prone to develop infective endocarditis. And let's assume if this patient never had any structural valve lesions, she all of a sudden starts developing infective endocarditis with signs and symptoms of CHF. What is the commonest predisposing factor for such a presentation?
IV drug use.
Excellent, IV drug abuse, right? So so that is the reason why you should think further, because later on when we are taking history, you should ask the patient whether she is abusing IV drugs or not. IV drug use, very important. All right. So, any other?
Yes, core pulmonary ተብሏል ግን as a
Core pulmonary by itself is not a diagnosis. Core pulmonary secondary to what?
maybe like pulmonary TB.
No, I mean, what is core pulmonary? It's just a sequelae of something, right? So what's core pulmonary, by the way? How do you define core pulmonary?
Right ventricular hypertrophy.
Yeah, right ventricular hypertrophy secondary to something, right? So right ventricle wouldn't be hypertrophic within days or within weeks. It has to be a very chronic process. So there are known causes why patients may develop core pulmonary. Can you give me examples?
Secondary to COPD.
COPD, yes.
Bronchiectasis.
Bronchiectasis. እነዚህ these pathologies which you categorize them as chronic pulmonary lung disease, chronic obstructive pulmonary lung diseases, obstructive lung diseases, specifically like, you know, COPD, asthma, you know, they are very important. Chronic bronchitis, bronchiectasis. Lelas. Long-standing, long-standing what? Pulmonary what? Long-standing pulmonary hypertension, right? So pulmonary hypertension by itself is a very broad category because, like, you know, it has its own classification, about 5 different classes, right? So, you know, it could be of any reason, you know, the 5 different classes as a explanation for pulmonary hypertension. So a patient with long-standing pulmonary hypertension may develop core pulmonary. So these are some of the reasons why people might develop, you know, pulmonary hypertension. So obstructive sleep apnea አለ, valvular heart disease አለ፣ ያው pulmonary hypertension 5 ክላስ አለው ብያቸዋለሁ። የተወሰኑት some of them are idiopathic, some of them are related to left-sided heart problems, some of them are lung pathologies, some of them are related to chronic pulmonary thromboembolism. So you can read about classification of pulmonary hypertension. So core pulmonary as a result of that could be one of them. A good explanation. So core pulmonary with right ventricular failure, right-sided heart failure can explain the lower extremity swelling as well. So it's a very good differential diagnosis. Okay. And it can also explain the shortness of breath, progressive worsening shortness of breath. Okay. Any other differential diagnosis?
Chronic kidney disease.
Huh?
Chronic kidney disease.
Chronic kidney disease with kidney failure can explain this, like, you know, patients might develop pulmonary congestion, patients might develop lower extremity edema because they could be volume overloaded. So CKD progressing to end-stage renal disease. So CKD by itself, it has its own classification. We have got CKD2, CKD3, further classified as CKD3A, CKD3B. We have CKD4, and we have CKD5, and then eventually in the stage renal disease when a patient is dependent on hemodialysis. Okay. So you should read about CKD classification. Okay. And CKD classification is based on GFR, glomerular filtration rate. Okay. And you should know the numbers. That's very important. Okay. So because CKD is a vague, broad terminology, it has at least 5 classes. And then eventually, once patient has become dependent on hemodialysis, we call it end-stage renal disease, which is requiring renal replacement therapy, either in a form of transplantation or in a form of hemodialysis, permanent, lifelong hemodialysis. Okay. Good. Any other differential diagnosis? So you are thinking of kidney pathologies, you are thinking of lung pathologies, you are thinking of heart pathologies. What else can result in, you know, an ASARCA? We are not sure whether this patient has an
Chronic
ASARCA or
liver
not.
disease.
A chronic liver disease can also present like this. Sometimes, especially CLD with decompensated liver failure, sometimes mimics a presentation of right-sided heart failure, right? So right-sided heart failure can be confused with chronic liver disease because their presentation, physical examination findings could be a mirror image, you know? So patients may have ascites, patients may have lower extremity swelling, and eventually they may develop an ASARCA, and even the significant distension of the belly with significant ascites pushing the diaphragm up can compromise the respiratory status of the patient, and patient may develop shortness of breath. So CLD is also another differential diagnosis. It can, you know, explain both symptoms. Anything else you want to? And the CLD could be of any sort, you know, cirrhosis due to alcohol, cirrhosis due to NASH, non-alcoholic cirrhosis. It could be due to viral illness, a lot of things, you know. So we didn't talk about details. So you can talk about cirrhosis with portal hypertension. You can think of viral hepatitis, especially hepatitis B and hepatitis C are very notorious in resulting in chronic liver disease. You can have NASH, non-alcoholic cirrhotic liver disease. Okay, and then many other causes, medication related, toxicities and all that. There are different causes for chronic liver disease. Hemochromatosis, ዊልሰንስ ዲዚዝ ነው የሚባለው ደግሞ ኮፐር ዲፖዚሽን ምን ዲዚዝ ነው የሚባለው?
Yeah, it's Wilson's.
Wilson's disease. There are many causes of chronic liver disease. So the main presentation is not CLD, so I'm not going to discuss them in detail, but you should think of possible cause. You cannot simply say chronic liver disease. Chronic liver disease due to what? So then if you are thinking of something, you have to ask during history, during physical exam, during lab investigation, you have to look for it, okay? Any other differential diagnosis you want to include, or you want to proceed? We can also add differential diagnosis later as we go along. If you want to add further differential diagnosis, we can add later on if you want to, okay? Anything else you want to add?
Can we consider myocarditis?
Yeah, myocarditis. Yeah, myocarditis. Myocarditis tends to be acute. Most of the time, the presentation is going to be acute. Patient will have chest pain at the same time, chest pain, shortness of breath, and it's going to be very acute course. Sometimes the course could be a little bit protracted, especially if the patient presents to you late. So you can think of myocarditis. It's going to be low in the differential diagnosis. But anything else you want to include? That's it? እንቀጥል ወይም እንጠራለን በሉ።
Question, like in the body swelling cause hypothyroidism መጥቀስ እንችላለን? Like a generalized body swelling አድርገን
The only problem is like, I will talk about this principle later on, or I will tell you right now. So when you are thinking of differential diagnosis, Betty asked a very good question last week, and I have to highlight it now so that I give you an idea. So when you are considering a differential diagnosis, there are different approaches. So you can think of any pathology which can explain. And if the patient has multiple complaints, try to find one good pathology which can explain all those presenting complaints. For example, CHF can explain lower extremity swelling as well as worsening shortness of breath. Chronic rheumatic heart disease, the same thing. Nephrotic syndrome, the same thing. They can explain both presenting complaints at the same time. Sometimes you may not be able to tie up everything with one possible differential diagnosis, and hence you may have differential diagnoses from different places. But in principle, try to, find a very good differential which can tie up all the potential, mentioned differential, presenting complaints. So, and to organize yourself, you can think of in terms of systems. So what can cause lower extremity swelling? Then you can talk about nephrotic syndrome, CLD, heart failure, malnutrition, which means hypoproteinemia. So that's also a very good differential diagnosis, by the way. So I am going to add below nephrotic syndrome, whatever in that area, malnutrition, severe malnutrition, protein energy malnutrition, severe protein energy malnutrition can also explain. So you can think like, liver disease, kidney disease, heart problem, lung problem. So can explain the shortness of breath. The shortness of breath. But the only thing, for example, I said the lung pathologies like TB, whatever, pneumonia, severe fulminant pneumonia, whatever. The only thing is the duration is against fulminant pneumonia, but if it was a short duration, fulminant pneumonia can be considered. But the problem is TB, pulmonary tuberculosis, fulminant pulmonary lung infections cannot explain the lower extremity swelling, and hence their being the main culprits would go down. And the same thing works with thyroid hypothyroidism. Hypothyroidism is known to develop pre-tibial edema. It doesn't result remarkably in edema. Sometimes it may, but it cannot explain, or it shouldn't necessarily explain, the worsening shortness of breath. And hence, if you mention, hypothyroidism just for the sake of lower extremity edema, I'm going to keep it really down in the differential diagnosis. So if I say headache, don't mention all the possible causes of headache. Try to consider epidemiology at the same time, the age of the patient, the sex of the patient, the duration of the illness. All these things has to be taken into consideration. So I may say headache and let's say shortness of breath of 2 days duration, then the differential diagnosis list will completely be different. So I would think of pneumonia, I would think of TB, I would think of any viral pneumonia or bacterial pneumonia, fungal pneumonia, whatever. I will think of acute heart failure and things like that. TB less likely because TB is like, longer. Chronic rheumatic heart disease is going to be less likely because this thing happens immediately, like, sudden onset of shortness of breath. I will think of heart failure, but not related to chronic rheumatic heart disease, okay? But I may think of infective endocarditis, valve perforation, valve prolapse, or valve regurgitation due to infective endocarditis. That can be a very important differential diagnosis for somebody with heart failure, which is acute. But chronic rheumatic heart disease is going to be completely excluded just based on only the presenting complaints duration, okay? So this is a principle you have to follow, okay? When you are thinking, when your brain is processing, consider the age, the sex, the duration, the complaint, what can explain these complaints, and then try to organize yourself like, in terms of organ and all that, if possible. If it is not possible, it's okay. You can go here and there, but later on you'll refine it. You got my point? This is a principle you should follow. This is a principle I follow in my day-to-day clinical practice. Okay. Having said that, hypothyroidism is going to be just to make you happy. I will keep it there, but less likely. To make you happy, I can add lymphedema. Right? Lymphedema can happen. It can result in lower extremity swelling, right? Silicosis, other parasitic infections from yeah, go ahead. But lymphedema cannot, remember, lymphedema cannot explain the worsening shortness of breath. I'm just keeping it just to go with your way of thinking, lower extremity swelling, differential. Okay, go ahead, please.
Congestive heart failure secondary to hypertensive heart disease.
Yes, yeah, hypertrophic cardiomyopathy could be related to hypertrophic cardiomyopathy has its own differential diagnosis. It could be related to like, long-standing untreated hypertension. It could be related to congenital hypertrophic cardiomyopathy. So HOCM የምንለው ማለት ነው. HOCM is also here. Hypertrophic obstructive cardiomyopathy. HOCM ይሉታል. It's a congenital pathology ነው. So hypertensive cardiomyopathy ሊሆን ይችላል ከሃይፐርትሮፊክ ስር ማለት ነው። ትክክል ነው. Related to hypertension. Excellent point. Anything you want to add? You see, we spend a lot of time mentioning differential diagnosis just based on by the chief complaint. And then now our life is going to be very simple because we are not going to repeat why we are considering this differential diagnosis later on. We have already discussed most of the things just at the level of the chief complaint. You got my point? Later on, our discussion would be refined. It would be easier. Okay, let's proceed. If you want to add differentials later on, you are more than welcome. If something pops up, you can always tell me. Okay, stop me and tell me. So to give you a little bit of personal identification, her name is AP, age is 35-year-old. She's female, she's married. Her occupation is secretary. She's a secretary in one of the firms, okay? So now tell me what questions you would like to ask AB. I am AB, ask me questions, I'll answer your questions. We are at the level of the HPI. Just give me one moment, okay? Just give me one moment, let me do something. Okay, go ahead, I'm here.
Okay, if there were any past medical illnesses.
No, no. I mean, like, this is HPI. So first, follow the principle of HPI. So past medical illness is part of the history, I know, but it comes after the HPI and it comes after the review of system. So first, elaborate the chief complaint, right? That's the basic principle. So go ahead and ask me questions.
Okay, what are the aggravating and alleviating factors of the shortness of breath?
I don't agree with you again, Ahom, with all due respect. Because, like, before you ask me about aggravating and relieving factors, you have to elaborate the chief complaint. You didn't elaborate the chief complaint. Maybe you go ahead. Okay, go ahead.
The duration of the symptoms.
The duration, I have told you in the chief complaint, it's 2 weeks duration. But this lady had shortness of breath over a long time, more than 2 years. She had shortness of breath here and there, but it just started worsening over the past 2 weeks. Nabiyu Tamaskan, you can ask questions. Raise our
When does the shortness of breath exacerbate or worsen? Is it with minimal activity or severe?
Excellent. So over the past 1 year, my shortness of breath was coming whenever I was doing, heavy exercise. But right now I cannot even cook. I cannot even stand in my kitchen. I really find it very difficult to reach to my bathroom. It's really getting worse, Doc. And now, like, the past 3 days, I feel winded even sitting in my couch.
When did the leg swelling start? Is it before the shortness of breath?
I do have I do have this leg swelling over the past year, but the past 2 weeks, it's really getting worse. Right now, I cannot even, fit my shoes, unfortunately.
Is the swelling of legs more pronounced during the day, or is it early in the morning?
It's constant. It's always present. It's always there.
How much is the swelling until the level of ankle or more than that?
ቅዱስ can you speak up? አይሰማኝም። ትንሽ ድምፅህን ጨምርልኝ።
The level of swelling እስከምን ድረስ ይደርሳል ማክሲመም ሲሆን እና በስንት ጊዜ ነው?
Yeah, it's constant. It's getting worse over the past 2 weeks. It has reached to the level of my thighs. So I'm really finding it hard to, even wear my tights and all that. So it has reached to the level of my thigh. It's getting worse. And it's always present day and night.
Do you have any cough associated with the shortness of breath?
Yes, I do have cough. Sometimes I cannot sleep as a result of that.
Do you have sputum associated with it?
Yes, I do have a sputum.
Can you tell me how much?
So it's about 2 Arabic coffee cups in 12 hours. It's getting worse.
ስትተኛ ምን ያክል ኪሎ ነው የምትጠቀመው?
Pillows, as I use 3 pillows at night. I cannot really lie flat.
Do you have any blood associated with the sputum?
No, it's just white, doctor. It's a very clear whitish flake is coming up.
Is it position dependent?
Which one?
The sputum.
No, whenever I'm coughing, something will come up and it's completely white. No blood in it.
Is there any sudden awakening from your sleep because of the shortness of breath?
What do you mean, doctor? Can you describe that to me further?
Do you have sudden awakening because of the shortness of breath and then you cannot relieve it by sitting up straight?
Oh, yeah. That happens to me quite often, in the past 2 weeks, yes. It wakes me up. It's very frightening. I feel like I'm dying when that happens.
Do you have an associated fever?
No, I don't have fever.
Any abdominal pain?
Yes, I do have abdominal pain, doctor.
Can you tell me where?
Yes, just located below my rib cage in the right side.
Any family history of sudden cardiac death or cardiac illness?
No. Oh, no. God forbid, no.
Smoking, alcohol?
What did you say?
Smoking or alcohol history?
Alcohol? No, I don't drink alcohol. I don't smoke cigarettes.
Any pregnancies recently in the last 6 months?
ድምፅህ ቅዱሴ, ድምፅህ is a little bit distant.
Any pregnancy in the last 6 months or something?
No, doctor, I wish. I mean, I'm sick, I'm married. My husband wants to have kids. I want to have kids. I'm really worried about that as well. We don't have a kid, but we are planning to have one. And I'm so scared because of my, my medical condition. It's really tough, doctor. I'm getting depressed because of this.
Did you have any sore throats while you were a kid that your parents have told you of?
Yeah, I remember as a kid, like, I used to have like multiple episodes where I was having this sore throat, and they told us something. I think they said tonsillitis or something like that. I used to have that when I was a kid very often.
Did you know if you ever got treated for it, or if they took you for it? Did you guys ever treated for that, for the tonsillitis?
I don't exactly remember, doctor. It has been a long time. I was a young girl, but like I remember having them. I don't remember what they gave me. I think they might have given me some antibiotics for the sore throats, but I don't exactly remember. You guys are doing a great job, but there is a lot of questions to be asked, so go ahead.
Do
Any
you have
medications?
hypertension?
No, I don't have any history of hypertension.
Do you take
What's
any
hypertension?
medication?
What's hypertension, by the way, doctor? I'm not clear with that.
You have a raise in your blood pressure?
High blood pressure? No. In fact, they sometimes tell me that my blood pressure is in the lower side. Anything else?
Do you have any medication use?
Yeah, of course. I mean, just like, for my problem over the past year, they have been giving me some medications and I am taking them.
Can you specify the medications? Do you know their names?
I do have the packet. I can give it to you later on. I will ask my husband to bring them. I don't remember them by name. I'm sorry.
Okay.
Do you have any history of prior TB infection or being treated for tuberculosis?
No. No.
Did you ever have like any change in color of your urine or
No.
like any eye swelling?
What do you mean by changing the color of urine, doctor?
I don't know how to ask it.
ከባድ ፔሸንት ነው ያለች ዛሬ ስለዚህ ተዘጋጅ በለ
I mean, has it changed color?
When you
meaning,
urinate,
like,
do you see any reddish?
What did you say, doctor? Dr. Betty, what did you say?
Have you ever noticed any discoloration of the urine? Color?
Oh, no. I mean, like, I look at it sometimes, but it's either white or sometimes a little bit of yellow, but I haven't seen something different. So either you have to say reddish discoloration of the urine or cola color urine or tea colored urine. These are the terminologies you should use when you are communicating with the patient. Okay. When you tell them like any color change, what do you mean by that? If they ask you, you have to specify. Okay.
how has your diet been
Are you
recently?
blurring of vision?
My diet, I mean, like, what do you mean by diet? I mean, any Ethiopian diet, I eat injera with shurwat, nothing special.
How many times per day do you eat?
Most of the times, 3 times a day. Sometimes I may eat something in between.
What do you constantly eat? I mean, is it like you mentioned injera with shiro, or do you tend to mix it up?
ቤት ያፈራውን ነው ዶክተርዬ፣ ያው መቼም አቅማችን ውስን ነው። ሽሮ በእንጀራ ነው በአብዛኛው። sometimes ምስር ወጥ እበላለሁ whenever it's available. Sometimes I may eat also ምንድን ነው የስጋ ወጥ፣ ቀይ ወጥ እወዳለሁ።
Any change in the color of
Change in the color of what?
your
Eyes?
Yeah.
Okay, no, I don't know. I didn't notice anything. I'm at, doctor, do I have any problem in my eyes? Not really. Sometimes when you ask questions like this, people would ask you, oh, what happened to my eyes? I think they are fine. I think they are fine, doctor. I haven't seen anything different.
Were you ever treated with a radiation earlier before?
Oh, what is radiation, doctor?
Wait, Raj. I mean, if you're not like
Raj, treated with Raj, doctor. Yeah, I know. Why? No, I know. You can simply ask by saying like, have you been treated for any cancer? Have you ever had any diagnosis with cancer? If I say no, then that's out of your question, And then like the right terminology is radiation in Amharic, like if they give you a positive history for cancer, no, otherwise it's not going to be relevant, okay? But you have to ask. That comes as part of past medical history, but it is also okay to include it in the GPI because it's relevant. It's part of a differential diagnosis. Any other question you want to ask?
Any history of weight
Is
loss?
there any
Weight loss? No, actually I gained weight, doctor. I am so worried about it. So I am gaining weight.
Easy fatigability, blurring of vision?
Oh my God, like, I can't even walk to my bathroom, doctor. My bathroom is almost 10 steps away from where I am sitting, but it's very tough for me to reach there. I feel winded. I cannot get there. And I am always fatigued. And like, I would be sleeping easy during the day sitting on my couch. And this has been going on over the past months.
Do you have any bringing of the ears or lightheadedness?
No, doctor, no.
a decrease in urine output?
I think it's fine. I mean, I haven't seen any change.
Nausea or loss of appetite?
Huh?
Nausea or loss of appetite?
I feel nauseated, doctor, and like, I'm also losing my appetite. I don't really have appetites these days, especially the past 2 weeks. My appetite is going downhill. I'm really concerned about it. And I always feel nauseated. And when I eat something like, my belly gets distended right away and I cannot really eat much. And this is getting worse over the past 2 weeks, unfortunately. Uh-huh. That's it.
Indoor pollution, cooking, some.
No, I mean, like, I live in a condominium, so I mean, we are not cooking in the house. We don't use firewoods and all that. So we use electric cylinders. So as such, we are not cooking. I mean, I don't have any smoke exposure or anything. Oh, do you want to proceed? Let me give you the details. Okay, you have asked most of the questions, but like, if you give me a differential diagnosis, then you have to ask those questions, which would help you to exclude that differential diagnosis. That is a basic principle, okay? So a positive history, negative history, they have equal importance. A negative history is equally important as a positive history, by the way, to include a differential diagnosis or to exclude a differential diagnosis. So I came with progressive shortness of breath over the past 2 weeks, initially with exertion, currently even at rest. I can't sleep flat. I use 3 pillows at night. Sometimes I wake up from sleep gasping for air. I have a chest discomfort, which is worse with exercise. You guys fail to ask this question. Chest pain. You should always ask a patient with shortness of breath about presence or absence of a chest pain. And this lady has a chest discomfort. I have bilateral lower extremity swelling. This has been going on for over a year, but it's getting worse the past 1 month. Has also noticed an increase in abdominal GERD. You guys didn't ask me about whether I have any history of abdominal GERD increase or not, because ascites can develop as part of the disease process. So my abdominal GERD has been increasing. I have been gaining weight. I have cough with no, I said scanty, but let's change it. I have a couple, like I said, 2 Arabic coffee cups over 24 hours. Whitish sputum, no blood in it, no fever, no night sweating. You should ask about night sweating. Those guys who have been asking about TB, if you are interested, you should ask about these constitutional or B symptoms. Has been experiencing palpitation. You guys didn't ask me about palpitation. If you are dealing with a cardiac pathology, especially if you are thinking of, rheumatic heart disease, complications like arrhythmias, especially atrial fibrillation is very common. You should have asked about this question. So I have been also experiencing chest palpitation over the past week. Okay. I have gained weight recently, has decreased appetite. I feel fatigued. And I am complaining of also right upper quadrant pain over the past week, which is associated with nausea. I have no vomiting. I don't have fever. I don't have chills. I don't have rigors. I don't have night sweating. Oh no, I have a chest discomfort. I'm sorry. Disregard this one. You can exclude this one. Let me edit this part. So chest pain, no chest pain is out. Okay, I have a chest pain. I said I have a chest discomfort, right? So yeah. You get it? So you guys should be really proud of yourself. So you have asked most of the questions. I don't have hemoptysis because one of you guys have asked me whether there is blood in the sputum or not. I don't have melena. No yellowish discoloration of that. Why is melena important? Melena. Why is melena important? Why is hemoptysis important? Why is hematemesis important? I don't have hemoptysis, hematemesis, or melena.
If CLDs are
Excellent. If CLDs are differential diagnosis, especially portal hypertension, patients may develop esophageal varices, and patients may bleed from esophageal varices, and they may come to you with hematemesis or melena. That's very important. Upper GI bleeding is a possibility, okay? And no yellowish discoloration of the eyes. I'm talking about, remember, why is yellowish discoloration of the eyes very important in this particular patient? Why is it important? Congestive hepatopathy, right? Because if a patient with heart failure, right-sided heart failure in particular, develops hepatic congestion, sometimes they may develop yellowish discoloration of the eyes. Or if we are dealing with a chronic liver disease, patients may develop they may have jaundice, okay? I have history of recurrent tonsillitis when I was a kid, since childhood. She hasn't been consistent with taking prophylactic benzathine penicillin G, and no history of cigarette smoking, no alcohol history. Most of the things you have addressed in the HPI. A review of systems. What other systems do you want to focus on? Other than the lung and the heart and the liver, probably. What other things do you want to include? GI, right? So I have nausea. I have right upper abdominal, upper quadrant abdominal pain. So, the explanation I already told you, a patient with heart failure, especially right-sided heart failure, may have hepatic congestion. So that may result due to, distension of the capsule of the liver. They may experience right upper quadrant pain. It could be associated with, constant nausea. And the ascites might be associated with early satiety and significant abdominal distension. And my abdominal GERD is increasing gradually. That tells you at least, some sort of pathology is going on. Most probably, ascites is developing in this patient. And the other system you have to focus is in the kidneys. So for the kidney, you have asked important questions. You talked about hematuria, presence of hematuria or absence of hematuria. That's very important because, you know, glomerulonephritis, glomerulonephropathies, you know, they may come to you with hematuria and proteinuria. So the proteinuria you can only diagnose by doing urinalysis, okay? So then musculoskeletal system, bilateral lower extremity significant swelling, which has been present over a year, but it was gradually worsening over the past few weeks, 2 weeks, okay? Is it a good summary, guys? Is it a good summary? ይከልላችኋል እንደ ይሄ እንትኑ ምንድነው ከጎን ያለው ስላይዱ ይታያችኋል አይደል? Can you see the slides well?
Yes, we can.
Okay, very good. So is it a good do you still want to ask further questions or anything you want to include? ወይስ ጥሩ ነው ያገኘነው history? I think we have enough, right? So, okay, then past medical history. No, I have history of hypertension. I'm so sorry. I'm so sorry. I have history of hypertension. I said I don't have earlier. I was diagnosed with hypertension 2 years ago. I am on lisinopril. I have follow-up and I have history of asthma. Okay. No history of diabetes, no history of dyslipidemia. I had recurrent history of tonsillitis in the past since childhood, no history of prophylaxis treatment. That's past medical history. Past surgical history, I don't have any past surgical history. Social history, you guys already have asked me. No history of cigarette smoking, no alcohol history, no recreational drug use. Okay, guys, so now it's time to narrow our differential diagnosis. So let me bring whatever we have written here, and then we will keep some of them and we will exclude some of them. So you will tell me the rationale why you want to keep it or why you want to exclude it at this level. Okay, guys? እና አሁን ፈጠን በሉ ቶሎ እንድንጨርስ ቶሎ ዲስከስ እንድናረግ ትንሽ ጥያቄ መስራት እንድንችል እናንተም እንዳይሰለቻችሁ እንድትወጡ አልፈልግም. Whoever has participated this far shouldn't leave this session without finishing it if possible, okay? Unless you are forced because of some unavoidable reason, okay? Now on, let's go through each and every differential diagnosis. So ቶሎ በሉና I won't keep ስትሉ ግን you have to justify, okay? Congestive heart failure secondary to cardiomyopathy of any sort. Constrictive. Do you want to keep congestive heart failure? Keep ማድረግ ብቻ ሳይሆን I want to keep it, but I want to take it down. I want to keep it, but I want to take it up. Or I want to keep it up, I want to keep it down. የሚለውንም አብራችሁ ብትጨምሩበት ደስ ይለኛል.
Keeping it is a good option because, like we've mentioned, the patient has a history of hypertension, even though I don't know for how long. So maybe keep making it in between, I don't know, 3 levels down or something.
So let's say, let me rephrase and you will answer my question. So congestive heart failure secondary to multiple causes, right? There are cardiomyopathies, which we say dilated, hypertrophic, and HOCM, and restrictive cardiomyopathy ብለናል. And poorly treated hypertension is one of them. ሌላው ደግሞ congestive heart failure related to chronic rheumatic heart disease ብለናል. So which one do you want to make the most likely differential diagnosis? Like, you know, you want to keep up. Which one do you want to keep up?
Congestive heart failure secondary to
chronic rheumatic heart disease. Yeah, most probably that is highly likely, right? You know, based on the history of sore throat. Reason being, this lady gave us having history of recurrent sore throats and have been treated for sore throats since childhood. So that increases the likelihood of having chronic rheumatic heart disease as a underlying cause for the congestive heart failure. So cardiomyopathy is either dilated. Does she have any risk factor for dilated cardiomyopathy? Not really. She's not alcoholic. And, you know, as such, ብዙ risk factor ያላት አይመስልም. Hypertrophic cardiomyopathy, she's hypertensive, but she has been treated with lisinopril, and I think her blood pressure was also, I didn't give you the vital signs, but when I give you, you'll see it. But she told you, she has been told in the past, her blood pressure is in the lower range. At least historically, she knows that her blood pressure was not elevated. That means they have effectively controlled the blood pressure. Okay, so the likelihood of hypertrophic cardiomyopathy due to untreated hypertension, is less likely. Is less likely. Okay. HOCAM, there is no family history of sudden cardiac death, right? So, and the likelihood of having HOCAM in this lady may be less likely. Still, it's a possibility. We don't know unless we do like echo and everything. Hypertension, we talked about it. Restrictive cardiomyopathy is also a possibility. You know, it's going to be a diagnosis to be made later on with investigation. So it's very tough to tell now. So, but chronic rheumatic heart disease, we have a very good reason to consider it to be the most likely differential diagnosis. We keep it high. Do you agree, guys? Do you agree, guys?
Yes, yes.
All right. ዜክስ አለ ኮመንቶቹን ብትነግረኝ አሪፍ ነው ካሉ ኮሜንቶች የሚጨመሩ
አለው እስካሁን ምንም ነገር የለም
የለም ኦኬ ኤክሰለንት ዜክስ you are the best okay እሺ constrictive pericarditis do you want to keep constrictive pericarditis due to TB radiation surgery
Not really.
not really አይደለም አሁን not really ብቻ ሳይሆን be firm I mean radiation no because she told you there is no history of cancer no treatment for radiation so radiation is completely out so I'm going to kick it out ለሱ ምንም መረራ የለኝም radiation is out so what about surgery surgery is also out she told you she never had any surgical intervention so you cannot keep that as a differential TB is it possible it could be, but TB, constrictive pericarditis, doesn't really come overnight. I mean, but the fact that this lady had these symptoms for a long time, over a year period, is also, it makes it valid. So we cannot really exclude it now. I'll keep it there. Constrictive pericarditis due to TB is a possibility. This lady actually didn't really endorse having the history of having been treated for TB in the past. So without that history, this becomes less likely. So since she didn't give us a positive history of TB treatment in the past, I'll cut it out. I'll keep it down if you want to keep it there. But if this lady had history of TB treatment in the past, she can still have this constrictive pericarditis as a presenting pathology. Okay, CHF with infective endocarditis, IV drug use, is it possible in this lady? Yes or no? In
No,
this lady.
she doesn't have a history of IV drug use.
Thank you, my dear. So infective endocarditis is out completely. It's deleted. It's out. Now we have more information, so we don't think about it. Okay, what else? Nephrotic syndrome. Do you want to keep or remove?
Remove nephrotic syndrome.
Most probably remove, but let's keep it for now because you never know. You may be surprised. You know what I mean? So you may see a very significant proteinuria and you may be surprised. So I will keep it down there. Less likely, but let's keep it there. We don't know. We never know. She may have nephrotic syndrome still. Okay, what else do you want to? Core pulmonary secondary to COPD, bronchitis, whatever. She didn't give us history of COPD. She didn't give us bronchitis history. She didn't give us history of chronic bronchitis. What did she give us though?
Asthma history.
Asthma. She gave us asthma history. So if it is poorly treated, it can result in core pulmonary. So still a possibility, but do you think her presentation looks like due to asthma? The asthma exacerbation? Less likely, right? If we think of core pulmonary, okay, but asthma, like, you know, I'm going to bring, let me show you around here. I'm going to bring here asthma exacerbation. Now you have more history. Now you know that she has asthma. So it could be asthma exacerbation. You never know. She may be worsening. She might have been worsening over the past 2 weeks. So asthma exacerbation is a possibility. But we will wait until we go to the level of physical exam and we will say something. Core pulmonary due to asthma is still a possibility. So we have to do what to see if there is core pulmonary or not. We have to do what?
Echo, maybe?
Yeah, echo. So short of echo, we cannot really say whether there is core pulmonary or not, whether there is pulmonary hypertension or not. We don't know. So we still keep it until we investigate this lady. And let's keep it there for now. What about severe protein energy malnutrition? I know you have been asking a lot of questions about diet. Maybe you have been thinking about it, right? Still a possibility, no, አይደለ? Severe pulmonary malnutrition. Protein energy malnutrition is a possibility if a patient has severe hypoalbuminemia, they may develop anasarca. The only thing is the way she presented. This has been going on over a year. So to think that this pathology or this problem is due to malnutrition is a little bit remote possibility. Theoretically it can cause anasarca, but her shortness of breath is not something new. So I don't think it explains everything. So I'll take it down. Okay, asthma is still a possibility. Asthma exacerbation or pulmonary secondary to asthma still possibility. CKD is progressive to end stage renal disease. Shall we keep it or kick it out? ምን አላችሁን?
Remove it because her urine output is not.
I mean, you never know. I mean, she may have CKD on top of whatever is going on, by the way. Like you mentioned, if I hear you correct, you are breaking up. Cardiorenal problem, cardiorenal syndrome is a possibility in this lady, right? If this lady has, congestive heart failure, she might have developed cardiorenal syndrome, and she might develop, compromised renal function. So not only because it's going to explain her symptoms, but it is really highly likely and it's high possibility that this lady might have CKD or AKI for that matter, acute kidney injury as a result of cardiorenal syndrome. So I will still keep it, not necessarily to explain her presentation, but it could also be existing in this particular patient. So I will keep it there. And especially if it has progressed to end-stage renal disease, patients may develop flash pulmonary edema, uncontrolled hypertension and everything. The only caveat, the only thing against end-stage renal disease though is like, this lady has adequate urine output, so that you cannot think of end-stage renal disease. She can have CKD, but not end-stage renal disease, right? The kidneys are still working. And her hypertension is not also out of proportion, it's controlled. That also tells you that the kidney is still functioning. If this patient was with end-stage renal disease, most likely they may develop like, uncontrolled hypertension, despite being on multiple antihypertensive medications. She told that she's only on lisinopril and the blood pressure, I told you, is most of the time she knows that she has been told repeatedly it's in the lower range. Okay. Okay, let's keep it for now. CLD, is it still a possibility?
No, it's not.
Why not?
Or maybe. She has a right upper quadrant pain.
Yeah, she has right upper quadrant pain. She has increased abdominal curve. Maybe it's ascites. We don't know if it is ascites or mass and we don't know at this point, but most likely she may have CLD. We never know. It's still a possibility. And CLD can explain the abdominal girth increment. It can also explain the right upper quadrant pain. It can also explain the lower extremity edema. And if the abdominal girth increases due to ascites, it can push against the diaphragm, and patients might experience shortness of breath. It can also explain our shortness of breath. So CLD is still a possibility. I'll keep it. The same principle with CKD is if it has resulted in anasarca. Okay. Asthma exacerbation, I talked about it. Okay, myocarditis less likely, right? So the chest pain is not really prominent. It's just a chest discomfort, and the duration may be a little bit against myocarditis because the presentation of acute myocarditis tends to be acute. It could be subacute. The myocarditis could be subacute. It could have a protracted course, but it looks like far-fetched. We can keep it if you want to keep it. We'll investigate further. Disseminated TB or pulmonary tuberculosis, we talked about it earlier. So she doesn't have any constitutional symptoms, no TB, no loss of, she does have some of the symptoms which may explain TB, but no differential waiting, no history of treatment for TB. You should also have asked about contact history. That's very important. In the HPI, you should have asked, have you ever had any contact history with TB or previous treatment with TB, especially if disseminated TB or pulmonary TB is in your differential diagnosis. So don't forget, you should ask these questions. You didn't ask these questions, so you cannot be firm to say that this is possible or it's not possible. So you can ask me now. I am giving you the answer. No prior history of TB treatment or no prior contact with a non-active TB patient. So we'll kick it out, okay? TB is not possible because it's missing in my history. I never had contact with a TB patient or whatsoever, okay? Severe malnutrition, it may not explain everything. It's less likely, we can keep it there. The lady was eating well until recently. What about PE? What about who is brave enough to include or exclude PE?
The patient did not have, I don't know, risk factor ብዙ የላትም, and the
No,
presentation
how do you know? How do you know that she doesn't have a risk factor? Did you ask her?
we didn't ask.
You didn't. So don't assume or don't conclude without looking for that answer. That's why I say, like, if something is in your differential diagnosis, ask a question. And both positive history, negative history is equally important to make a differential diagnosis, either a possibility or less likely, okay? So this lady doesn't have risk factor, no recent flight, no recent long distance travel. She is active. She has been active. The only thing was like, the past 2 weeks due to the shortness of breath, she was kind of less active because she feels winded. Other than that, like no recent surgery, no immobility, and she's not taking any oral contraceptive pills. You should also ask for P, you should ask for like, contraceptive use or not. I am not using any contraceptive pills or any injectable hormonal contraceptives. Okay, that's very important. And I'm not also a smoker, so risk for DVT is less likely in this lady. So PE, now it looks like a less likely differential diagnosis. And on top of that, the way the lady is presenting cannot be entirely explained by PE. The presentation is a little bit protracted, 2 weeks, so that is not typical of PE, acute PE. And the other thing, less risk factors. And PE also wouldn't be explaining the lower extremity swelling, except in one condition, unless she has a massive PE where she has got right ventricular strain, right ventricular failure, and that can explain, like, massive PE with right ventricular strain, right ventricular failure come present to you with right side signs and symptoms of right sided heart failure. That is missing. So in that sense, PE still can be a differential diagnosis. The only thing against PE is lack of risk factors and also the duration. So do you want to keep PE or kick out PE? It's debatable. Do you want to keep it or kick it out? And PE does not really explain the long-standing lower extremity swelling, and it doesn't explain the long-standing shortness of breath. This has been going on. The presenting complaint is just worsening of shortness of breath and worsening of lower extremity swelling. So PE should be out. If it was an acute thing, just 2 weeks or 3 days of lower extremity swelling and sudden onset of shortness of breath, PE is a possibility, especially if it is massive PE resulting in right-sided heart failure. Now, I kicked it out because this lady was sick for over a year. ግልጽ ነው? Do you like my reasoning?
Yes.
Good. What about hypothyroidism? Already we talked about it, so I'm going to kick out hypothyroidism. And whoever has said hypothyroidism didn't even ask a single question about hypothyroidism symptoms. Fatigue, okay, lower extremity edema, okay. So not being interested about the surrounding, cold intolerance, swelling, any swelling in the necks. These things should be asked. Symptoms of depression, symptoms of lack of interest in the surrounding and things like that should be asked, at least if you are thinking of hypothyroidism. And you should also ask about sleep pattern, okay, whether the patient has a good sleep pattern or not. You should ask about hair status, whether she has easy peeling out of the hair or not. You should also ask skin changes, okay, any skin changes, especially in the lower extremity, skin edema, skin thickening. Okay, you should have asked all these questions. You should have asked about menstruation cycle irregularity. That's very important. And in all ladies who are in the reproductive age group, as part of your history, ask about sexual history. That's very important, sexual history. And ask them about last normal menstrual period. That's very important because this lady, you are going to treat her eventually. You are going to expose her to a certain investigation eventually. So for that reason, you need to have this information in the background. You cannot send a lady in a reproductive age group without checking for pregnancy test for radiation exposure, like CT scan or chest X-ray. You have to ask if it is early pregnancy, early trimester pregnancy, and miscarriage happens. Then you can be like, sued for that reason, if you proceed without checking, pregnancy test. So always make it a habit to ask last normal menstrual period, ask about sexual history, whether with the same sex, with the opposite sex, whether they are using any prevention, protection like condom or anything, any contraceptive methods. All this information is missing. You don't have this information, then you cannot be really confident to say whether this is happening or not happening. Recent pregnancy, recent birth is very important, whether that lady delivered recently. Somebody asked me whether she gave birth recently or not. If she gives you a history of birth 2 weeks ago, what differential diagnosis would you add?
Peripartum
I gave,
cardiomyopathy.
huh?
Peripartum cardiomyopathy.
Excellent. Kudus. Peripartal cardiomyopathy would be your differential diagnosis. And patients, I had a patient with peripartum cardiomyopathy recently. She came with acute heart failure after 2 weeks of delivery. Okay. I have seen a couple of weeks ago. So that's very important. So sexual history, recent pregnancy, last normal menstrual period. All this is very important information in this particular patient. Okay. As feedback. Okay, lymphedema, less likely. Lymphedema doesn't really explain whatever is going on. It doesn't explain everything. It doesn't explain the abdominal girth increment. It doesn't explain the right upper quadrant pain. It doesn't explain the shortness of breath. It doesn't explain the cough. It doesn't explain most of the complaints, except the lower extremity swelling. So it's kicked out. I won't be keeping it. Nephrotic syndrome is still a possibility. Constrictive pericarditis due to TB is less likely now, because I told you I never had any treatment for TB, and I told you I never had any exposure to tuberculosis, at least recently. So TB pericarditis is also out now. You get it? እንቀጥል? አሁን ሞስት ኦፍ ዘ ጃብ ሰርተነዋል። ባይዘዌ አትጨናነቁ። ቤድሳይድ ባይዘዌ 2 ሰዓት 3 ሰዓት ከኔ ጋር ቤድሳይድ 4 ሰዓት ምናምን ይፈጅ ነበር ቢካዝ በቀላሉ አንላቀቅም እንደዚህ ዲቴይል ስለምንሄድ ማለት ነው። እና we are covering a lot of topics ደግሞ mind you. If it was a simple straightforward CHF presentation, it's very easy. I can talk about CHF, አለቀ። እዚህ ጋር ግን we are discussing about multiple pathologies, whether they are possible or whether they can be differential or they cannot be differential. We are touching multiple things. ስለዚህ if it takes a longer duration, I wouldn't be surprised. So don't be bored. የምንለማመጣችሁ እኮ እንዳታንቀላፉ ነው። Are you guys engaged? Yes or no በሉ። አሁን ቻቱን አየዋለሁ። Are you guys engaged? If you are, yes. If you are not, thumbs down or no. Comment on the chat box. I am watching. Good. ሶስት ሰው ብቻ ነው ግን የስ ያለኝ፣ ሌሎቻችሁ በዝምታ ተቃውሟቸውን የገለጻቸው። yes excellent good። እኔም እየለፈለፍኩ አልደከመኝ እንኳን እናት። በጣም አሪፍ። እሺ ቶሎ ቶሎ እንቀጥላለን። አሁን ጥሩ እያዳከምን ነው። ከዛ አሁን the next step is just to do physical examination. So what physical examination, what do you expect in a physical examination? ቶሎ ቶሎ መልሱ። Yes, start excellent. I really like you a lot. So you start from the general appearance. So how do you expect this patient would look like?
With shortness of breath,
Shortness of breath, okay.
visible swelling.
Yeah, some sort of puffy face, whatever. So acutely sick looking not, in severe respiratory distress not in pain, oxygen via nasal prong ተደርጎላታል. And the initial vital signs, so after general appearance is vital signs, right? So BP 95/80, heart rate is 109 per minute. It's irregularly irregular. Respiratory rate is 27 per minute. Temperature 37, saturation is 89%. Actually, before the oxygen oxygen was there, I mean, before the oxygen was given to her, her saturation was 89%. That's why I said initial vital signs. It just improved after she was started on oxygen. And HNT is very important. What do you expect in the HNT? What do you specifically look for in the HNT? Huh?
pallor of the conjunctiva.
Yeah, so you look for pallor because anemia is very common in heart failure. And anemia can also result in heart failure. If a patient has severe anemia, they can develop heart failure. So the type of heart failure we get is hyperdynamic heart failure. Okay, good. So we look for anemia, so conjunctival pallor. What else?
Yellowish
Yellowish discoloration because we are considering a possibility of CLD, even like CHF with congestive hepatopathy, we may develop some degree of jaundice. Okay, what else? So HNT mild pallor, no icterus, distended jugular veins in the neck. Lymphoglandular system, as such, there is nothing. Which other system do you want to examine in this lady? Lymphoglandular ጋር ደርሰናል። ቀጥሉ።
Just
Yeah, chest examination. Don't say respiratory system because we don't say respiratory examination of respiratory system because the respiratory system includes the trachea, the bronchus, and everything, right? So, but now we can examine only the chest. So say chest examination, not respiratory system examination. Terminology is also very important. During review of system, you can say respiratory system, but during physical examination, you don't say respiratory system, you just say chest examination. During review of system, you can say the abdomen, but no, you can say the GI system or gastrointestinal system. But during physical examination, you report it as abdominal exam, not examination of the GIT, because the GIT starts from the mouth, pharynx, esophagus, the stomach, the small intestine, large intestine. So that requires something else. You cannot examine the entire GIT. So you examine the belly, so abdominal exam. So terminology is very important, okay? Some people might give you a hard time. Some examiners might give you a hard time just because you say it GI or respiratory system examination. So examination of the chest, the patient is in labored breathing, that we can tell even in general appearance. We said she's acutely sick looking in severe respiratory distress. So there is labored breathing, has bilateral basal, and there is use of accessory muscles. And she has bilateral basal dullness, has bilateral crackles with bilaterally reduced air entry in the bases, in the posterior basal lung fields. Okay, she has basal dullness, bilateral crackles, as well as bilaterally reduced air entry basally. Okay, you will interpret this later on when we are done with physical examination. What other system do you want to examine? And there is no wheezing. Okay, I want to add something here. No wheezing. Why is that important? No wheezing. Huh?
She said she have asthma and
She has asthma. Excellent.
Yeah.
And you want to know whether there is an acute asthma exacerbation or not. So no wheezing means at least rest assured there is no asthma exacerbation. At least asthma exacerbation is not the main reason why she is having like this worsening of shortness of breath. Sounds good. What other system? So how do you interpret the chest examination finding? She has use of accessory muscles, bilateral basal dullness, and bilateral crackles with reduced layer entry. What does that mean?
Pleural effusion, bilateral pleural effusion.
Yes, she has bilateral pleural effusion and she has bilateral, yeah, because as you know, dullness a lot, reduced air entry a lot. So most probably we are dealing with someone who has bilateral pleural effusion. Okay, is it? Yeah, we'll talk about it later on, like, you know. And cardiovascular is continuous, raised, no. So the next step is cardiovascular exam. So what are the things you look for in cardiovascular exam? So cardiovascular examination includes assessment of the peripheral pulses and examination of the precordium, right? So what do you expect in this particular lady? Come on, guys. What do you expect?
Well,
Huh?
she has an irregular rhythm on her pulse rate, so
Yes, irregular rhythm, most probably she's having some sort of arrhythmia. And the heart rate is also 109, you know, you know. So she has tachyarrhythmia. At least we can say she has tachyarrhythmia, right? She's tachycardic and she has arrhythmia. So we can say she has tachyarrhythmia. Okay, go ahead.
and as well as maybe signs of hypoperfusion with feeble pulse.
Yeah, you may see some feeble pulse. What else? Actually, pulse is dependent on what type of, like, you know, valve pathology you are dealing with. If it is aortic regurgitation, ምናምን, you know, but you may have, like, you know, the collapsing pulse ሊኖር ይችላል, bounding pulse. If you have aortic stenosis, feeble pulse ሊሆን ይችላል. You know, depending on the vascular pathology, the valvular pathology, if you are actually dealing with the valvular pathology, the pulse could be different. So at least it's characterized as irregularly irregular. No other characterization has been mentioned. And she's tachyarrhythmic. What else do you expect in the cardiovascular examination? ቶሎ ቶሎ ታውቁታላችሁ እኮ አትፍሩ።
Well, in the precordium, signs of cardiomegaly with
ከፕሪኮርዲየም በፊት ናሆምዬ, be systematic. Don't jump into the chest. Before you jump into the chest, what else can
venous
you see?
system.
Excellent. So you can assess the veins in the neck, right? ስለዚህ tell me, what do you expect in the neck? I told you actually.
Yeah, distended neck veins.
Yeah. So what do you check for in the neck?
The JVP.
Thank you so much. Thank you so much, my dear. So JVP, whether it is elevated or not, you know, raised ነው አይደለም የሚለውን you have to assess for JVP. Okay. What else? አሁን ፕሪኮርዲያል ኤግዛም ላይ መሄድ ትችላለህ። ይሄን ኤክስፔክት አደርጋለሁ ብለህ ንገረኝ።
Cardiomegaly, maybe SC gallop fluid overload ስለሚኖረው.
Be systematic. Naomi, let me give you a hint. When you are reporting system, there are 4 cardinal signs and the steps, right? 4 cardinal systems in doing physical examination, which is inspection, you use your eyes, and then which is palpation, then percussion, and auscultation. So be systematic. Tell me what you expect when you inspect the precordium. And then tell me what you expect when you palpate, tell me what you expect when you percuss, and tell me what you expect when you auscultate. Okay?
Okay. So when we inspect the activity of the heart, is it quiet or is it active?
Not the activity of the heart, the activity of the precordium. Precordial
Yes.
activity. Yes, precordial activity. Good. Okay, excellent.
Yes, the number of pulsations visible on the precordium and the approximate location of the pulsations. And if there is any bulging of the precordium, which could be a sign of chronic rheumatic heart disease, as well as those our patient has no history of surgery, previous surgical procedures such as valve surgery, maybe seen scars, surgical scars.
Yes, excellent. እዚች ሌዲ ላይ ግን ስካር ኤክስፔክት አታረግም። ኤክሰለንት ፖይንት። ኦኬ
ኢንስፔክሽን ላይ እነዚህ እና ዜን ዊ ዊል ሙቭ ኦን ቱ ፓልፔሽን። ኢንስፔክሽን ላይ የረሳሁት ነገር ያለ አይመስለኝም።
You are doing great. Go ahead. ቀጥል።
On palpation, initially the location of the apical impulse እንፈልጋለን
Excellent.
which is the lowest and the most lateral pulsation.
Okay.
So usually in patients with fluid overload, cardiomegaly ስለሚኖር it will be pushed to lateral to the normal apical impulse ከmid clavicular line laterally ሊርቅ ይችላል and downwards 7 space lateral to the mid clavicular line at least 2 centimeters ነው example yeah. Then we characterize the strength of the pulsation, sustained or non-sustained. The point of minimal impulse characterize እናደርገዋለን location is it diffused localized የሚለውን እና amplitude sustained and sustained መሆኑን this patient ላይ location diffuse የመሆን chance አለው cardiomegally expect ስለምናደርግ hypertensive ስለሆነች maybe sustained ሊሆን ይችላል the amplitude of the PMI ከዛ በኋላ on palpation ሌላ palpation of the heart locations ላይ maybe and if there are any thrills or heaves check እናደርጋለን መርመር ሊመስል የሚችል
What is a thrill? What is a thrill?
The thrill is where we put the ball
What
of
is
our
a
hands.
thrill? Tell me definition, not description. Tell me the definition of a thrill.
It's a tactile sensation which we feel like a cat is purring or something.
So what is the definition you are describing again? What is the definition of a thrill? Anybody who wants to help him?
Palpable murmur maybe.
Excellent. That's it. It's a palpable murmur. That's it. Palpable murmur. And what is a heave?
Heave is the thrust or the lifts from the precordium.
Yeah, so precordial lifting, like, lift ያደርጋል. And that's a sign of what?
Hypertrophy.
That's a sign of what?
Hypertrophy. Ventricular hypertrophy.
Ventricular hypertrophy ወይም ventricular enlargement ነው አይደል? ስለዚህ ventricular እንትን ሲኖር ሊፍት ያደርግልሃል። So there are two types, apical heave አለ and parasternal heave አለ. Parasternal heave is related to right ventricle and apical heave obviously it's related to the left ventricular enlargement ማለት ነው. So the presence of a heave, the presence of a thrill. So how do you confirm that there is a heave on physical examination? What is the best way of demonstrating whether a heave is present or not?
Putting a piece of paper over the precordium.
Yeah, so you put it here, and then if it is lifting, like if the precordium is very active, do you see it? I think it's blurred ያደርጋል መሰለኝ. I was trying to demonstrate. እና እንትን ይላል ያ ብቻ ፔፐሩ እንደዚህ ይንቀሳቀሳል ማለት ነው ብድክ ሊፍት ሲደረግ ታዩታላችሁ ወይም you can put your hand on the precordium like this and you can see your hand being lifted up እንደዚህ ሲገፋ ታያላችሁ ወይም to make it easy you put a piece of paper on the precordium and you see its movement ማለት ነው whether there is a heave or not you can ascertain that way. And then, of course, do you do percussion in cardiovascular in precordial examination?
No, it's not actually practice.
You said no.
Maybe.
Okay, you said no. Is there any reason to do percussion in precordial exam? Somebody else?
Yes.
For what reason?
If there is any dextrocardia or situs inversus.
Dextrocardia, situs inversus. Okay, what else? I know these days it's not necessarily to do that, but like, if you are in a resource limited setup where there is no access to X-ray or where there is no access to echocardiography, do you want to do percussion? And for what reason? Yeah, just people, will try to outline the outline of the heart by, percussing in the past. This is historical. I've never done it since medical school. I've never done it, but theoretically, you can somehow check the cardiac border and to see whether there is cardiomegaly or not. People have been doing it in the past. Historical significance, at least theoretical. Okay, we don't need it. You have just X-ray, it will tell you whether there is cardiomegaly or not. You can do echo that tells you whether there is cardiac enlargement or not. So, and then finally is going to be auscultation. During auscultation, you may expect murmur, you may not expect, you may expect additional heart sounds and all that. Okay. So let's see what she has on cardiac examination. Raised JVPs at the angle of jaw, irregular pulse, active precordium, PMI at the left 6 intercostal space, displaced lateral to the left midclavicular line, apical and parasternal heave is present. She has palpable trill at the apex. S1, S2 are well heard except at the apex where they are muffled. S3 is present. Has a pansystolic murmur best heard at the left fourth intercostal space in the parasternal region, accentuated with deep inspiration. There is a separate holosystolic blowing murmur at the apex, radiating both to the back and the axilla. And patient is in the left lateral decubitus position. Has also a rumbling murmur at the apex. So in summary, what do you think is going on? What lesions does this patient have based on these findings? Hmm? The XST chat box yeah, she has TR, she has MR, she has MAs. Excellent, Natsanet. She has multivalvular heart disease, at least mitral valve and tricuspid valve are involved. She has murmurs of TR, MR, and MAs. The fact that there is trill tells you that grade ስንት ሆነ ማለት ነው መርመሩ at least apex ላይ ያለው መርመር grade ስንት ሆነ and the trill is systolic trill, okay? Palpable systolic.
Grade 4.
Grade 4. At least MR. You know the grades, right? So 5 ሲሆን ስንት ማለት ምን ማለት ነው?
If it is here, half of the stethoscope, you can say that.
Yeah, so the stethoscope partially touching your chest, the chest of the patient, and you can appreciate the murmur. It's grade 5. If you can appreciate or hear the murmur with the stethoscope placed off the chest, that's grade 6. Okay, very important. Thank you so much, my brother. Okay, extremities. She has bilateral lower extremity swelling with positive grade 4 pedal edema, ankle edema, pretibial edema, and sacral edema, which is pitting, no skin erythema or ulceration bilaterally. Edema grading ግን በዛው እንድትከልሱ ብዬ ነው ያስቀመጥኩላችሁ. What's grade 1, what's grade 2, what's grade 3, what's grade 4. In this case, our patient has grade 4 pedal, as well as ankle, as well as pretibial and sacral edema. So what's your diagnosis based on this finding? Only in terms of the swelling. Is it anasarca? Is it localized swelling? መልሱ እንጂ. Are you guys here or you slept? Hello? Yeah, go ahead, please.
Okay, it seems like she has an abdominal swelling as well. So, in addition to the bilateral leg swelling, so we might consider that it might be an anasarca.
And if I exclude ascites and pleural effusion, she does have pleural effusion. We talked about it earlier. And now she has up to sacral edema. So without ascites and pleural effusion, if I tell you she has sacral edema and lower extremity swelling, would she qualify anasarca as anasarca? Yes or no?
It would need to involve the face.
It would be what?
It will need to involve the face as well.
No, it shouldn't. Actually, like, if you have like, sacral edema, that fulfills the diagnosis of anasarca as far as I remember. So, and then taken all together, she has ascites. I'm going to talk about it now, but like she has pleural effusion and she has edema up to the level of the sacrum. It's generalized edema or body swelling. It's anasarca, in other words. So she definitely fulfills anasarca definition just by the fact that she has like, sacral swelling. So abdominal exam, distended abdomen, full flanks, no visible scar or peristalsis, no visible abdominal wall vessels, moves with respiration, positive fluid thrill and shifting dullness, mild direct tenderness over the right upper quadrant region, liver is palpable 8 centimeter below right costal margin, total liver span is 12 centimeter, slightly tender, blunted edge, no rebound tenderness, no other mass or organomegaly, digital rectal examination hasn't been done. So what's your interpretation of the abdominal findings? Come on, guys. Straightforward.
Ascites with tender hepatomegaly.
Excellent. So she has ascites with tender hepatomegaly, most probably. And then I told you that the age is blunted, right? So what does that tell you? Huh?
Congestive
Yeah,
hepatomegaly.
it's most probably congestive hepatomegaly. And the fact that there is hepatomegaly would exclude other causes like, cirrhosis and everything, right? With portal hypertension. Because most of the time you don't really expect the liver to be enlarged as much as this one. If a patient has CLD due to cirrhosis of alcohol origin or, hepatitis C or hepatitis C chronic infection with these viruses, So this piece of information is telling you about differential diagnoses at the same time, whether we are going to keep some of the differential diagnoses or you would exclude them. So now we are coming to the end. So stay with me, okay? Stay with me. Let's narrow. So other systems you want to examine, other systems, no pertinent positive findings, CNS and everything is unremarkable. Let's narrow our differential diagnosis. So we have this much of a differential hanging. Now with the physical examination findings, we should be able to narrow down some of the differential diagnoses. Okay, so be fast. ቶሎ ቶሎ ንገሩኝ። አሁን ጊዜም እያለቀብን ነው። ቶሎ ቶሎ ንገሩኝ። የትኛውን ኪፕ ማድረግ ትፈልጋላችሁ?
Let's remove asthma exacerbation.
ቆይ አንድ ጊዜ ይቅርታ። አይ ዶንት ኖ ለምን እንደዚህ እንደመጣ አላገባኝም። Right. Come on.
Doc, new slide, great.
አይ ሰራ። እሺ congestive heart failure secondary to chronic rheumatic heart disease, shall we keep it?
Yes, we should keep it.
Yeah, multivalvular heart disease ሆኗል። አሁን እንደውም MR multivalvular heart disease, we have TR, we have MR, we have MS. Okay. Cardiomyopathy, less likely, right? So it's still a possibility because sometimes you may have vascular. The only thing you cannot explain by dilated cardiomyopathy is presence of diastolic murmur. So these valvular heart diseases may develop, especially TR and MR can happen. Functional dysfunctions can happen whenever there is this dilated cardiomyopathy can give you murmur of MR. TR is likely unless a patient has developed pulmonary hypertension and all that. And functional these are less likely. We can still keep them. Hypertension, less likely. Restrictive cardiomyopathy, I don't think there is restrictive cardiomyopathy. Restrictive cardiomyopathy ከሚያመጡት እነዚህ invasive diseases የሚባሉት ናቸው አይደለ? What examples do you give me? Sarcoidosis, what else can you give me? Amyloidosis and all that. Yes, amyloidosis, especially hypertrophic cardiomyopathy. And amyloidosis can explain nephrotic syndrome, right? So if a patient has amyloidosis with nephrotic syndrome, they may develop hypertrophic cardiomyopathy. They may also develop anasarca. Okay, that's a possibility. So most probably we are dealing with chronic rheumatic heart disease with multivalvular heart disease. Mitral valve prolapse, less likely. The murmur characteristic doesn't go with that. For pulmonary secondary to asthma, less likely. It doesn't explain all these things we get. We do have these valvular lesions. Asthma less likely. There is no wheezing. We say it's CKD progression to the end-stage renal disease. Explaining all those, no, less likely. I mean, she can have CKD. I will keep CKD because the patients may develop, she may develop concomitant CKD due to cardiorenal syndrome, but it doesn't explain the murmur, it doesn't explain her clinical condition, it doesn't explain her findings and all that. So CKD as a concomitant differential diagnosis, it can exist together. Okay, hepatorenal syndrome is also a possibility because now this patient has already congestive hepatopathy. She may develop cardiohepatic syndrome as well, and patient may develop, decompensated liver failure as a result of that. So see, we can keep that one. Hepatorenal syndrome and cardiorenal እና ካርዲዮ ምንድን ነው ያልኩት ቀደም? ካርዲዮ ሬናል እና ካርዲዮ ምንድን ነው የሚባለው? በእናታችሁ እስቲ አስታውሱኝ። ካርዲዮፓቲክ or there is something. The liver can be compromised due to the heart disease. Search and tell me the right terminology. Brain shut አረገ። Myocarditis is less likely አይደል? እያወጣሁ ነው። አትቃወሙ። ስትቃወሙ ንገሩኝ። Why are you taking out ምናምን በሉኝ። Asthma exacerbation
congestive hepatopathy ነው።
ያ ሶ እነዚህን ናሽ ቫይራል ሄፓታይትስ ምናምን እናወጣና we can say congestive hepatopathy. No, I am also talking about
hepatorenal syndrome.
Hepatorenal syndrome is something else, but just like cardiorenal syndrome, እንደሱ የሚመስል ነገር የለም. I think there is. I forgot about it.
Cardiac cirrhosis.
Yeah, cardiac cirrhosis is a possibility. Yeah, but what is against cardiac cirrhosis?
The hepatomegaly.
The hepatomegaly is against that. So I'm going to, instead of cardiac cirrhosis, congestive hepatopathy is much more likely. So this is a manifestation actually. This CKD, cardiorenal and congestive hepatopathy, they are just manifestations of the disease process, complications which has happened as a result of the congestive heart failure. እንትኖች አይደሉም. They are not the primary diagnosis, secondary diagnosis ነው. So primary diagnosis ብለን primary diagnosis ይሄ ነው. ከዛ secondary diagnosis ብለን ደግሞ እነሱን መያዝ እንችላለን. Congestive hepatopathy, nephrotic syndrome, is it still a possibility? Theoretically, yes, but the only thing with cardiorenal and congestive hepatopathy in the secondary diagnosis is actually nephrotic syndrome is still a possibility. We have to wait until we investigate. But the only thing is it doesn't really explain the heart murmurs the patient is having, right? So for that reason, we can take out nephrotic syndrome. Theoretically, it's a possibility. Malnutrition is also a possibility, but it doesn't explain all the murmurs and everything. And the cardiac cachexia የሚባላል አይደለ? Cardiac cachexia. Because these people with heart failure, chronic heart failure, they will have a very significant reduced appetite. And they may be cachectic, they can have very poor appetite and all that. So if the patient is cachectic and everything, that tells you the patient is heading into end-stage heart failure. Okay, so as a secondary diagnosis, you may keep these things: congestive hepatopathy, CKD, cardiorenal, cardiac cachexia. They may be present in this patient. We don't know. We will see by doing investigations. But the primary diagnosis, we can say for sure now, most probably congestive heart failure related to chronic rheumatic heart disease, or we can say multivalvular heart disease secondary to chronic rheumatic heart disease. Most probably that's the primary diagnosis. Investigations, tell me the investigations. So basic investigation, hemoglobin is stained. So we said there is mild pallor, so that explains the anemia. So interpret the finding here. Tell me. So now you see BMP, you see the CBC. Tell me what abnormalities you see and why that is happening. Ladies, እስቲ ከሴቶቹ መካከል ድምጻችሁ ጠፋብኝ. Our sisters. Are you here? Nasanet, is it a she or a he? TG. TG, can you say something? Maaza, can you say something? One of you, Efrata. Are you guys with me? Allah. Don't tell me. Okay.
Steve,
አለን እኛ እንግዲህ
እሺ በሉ እስቲ በቃ ወንድሞቻችን እስቲ እንትን ተዋደቁ እስቲ ብቻዬን ቀረው እኮ
The hemoglobin is thin, so she is anemic.
She's anemic. Okay.
The anemia could be due to anemia of chronic illness, or it could be due to nutrition.
Excellent. You are the best. It could be related to nutrition. It could be related to anemia of chronic disease, or it could be also due to what? Due to what?
The joint might be swollen up, so they might not be able to absorb nutrients.
Yeah, nutrition guy ይካተታል. ግን ሌላ cause. Now she has MS እና MR አላት እያለን እኮ ነው. Could it be related to the valvular heart disease? የተወሰነ distraction እዛ ሊኖር ይችል ይሆን? A little bit of mechanical hemolysis could be there, especially actually that's very common after a prosthesis valve is present, but you know that's also some way. So MCV 75. So what does it mean? How do you interpret as MCV of 75? What does that mean? Macrocytic anemia no, microcytic no, normocytic anemia no. Microcytic anemia. So that explains, I mean, like, you know, most probably this lady may have nutritional deficiency, poor iron intake and everything. She could be iron deficient. Okay. So what other findings do you see in this valley?
The creatinine is elevated.
The creatinine is elevated 1.7 and GFR is how much? 56%. Is it normal or abnormal? It's abnormal. So she has CKD, right? Chronic kidney disease. This GFR, I'm telling you, has been like this. Creatinine has been elevated for the more than 3 months. I looked back 3 months ago, it was 1.8. GFR at that time was 52. So that means this process has been going on. She fulfills the criteria for CKD. So it's a secondary diagnosis. She may have a component of, if she develops AKI, that means she's developing like, you know, cardiorenal syndrome due to the florid heart failure. And CKD class ስንት 56% CKD ስንት ነው? CKD 3 አይደል? ከ60 በታች CKD 3 ነው። ከ30 እስከ 60 CKD 3 ነው። ከዛ ለሁለት ይከፈላል። ከ30 እስከ 45 CKD 3B ነው። ከ45 እስከ 60 CKD 3A ነው. So she has CKD 3A with elevated creatinine. If I tell you the creatinine last week was 0.9, then she has developed AKI, right? Because AKI diagnosed ለማድረግ the creatinine elevation more than 0.3 ስለሚባል ማለት ነው። አንድ criteria እሱ ነው. So AKI on top of CKD3A አላት ማለት ነው. Most probably we are dealing with cardiorenal syndrome ማለት ነው. Sodium is 129. What does that tell you?
It is one of the complications of congestive heart failure, and there will and it's also one of the prognostic factors in patients with heart failure with severe hyponatremia conferring poor prognosis in patients.
Okay, is it severe or moderate hypokalemia this patient is having?
In our patient, it is a mild hyponatremia, a
It
moderate
is
hyponatremia.
moderate hyponatremia because classification 130 and above is mild, and the 120 up to 129 is moderate, less than 120 is severe hyponatremia. So this patient most probably has chronic hyponatremia that is related with congestive heart failure due to volume overload now. Okay, and bicarbonate is 30. What does that tell you? Is it elevated, normal, low?
It's a bit
Huh? It's elevated, Adel. Most of the time, bicarbonate level has to be between around 22 to 26, right? So yeah, sometimes lab variation ትንሽ ሊኖር ይችላል. So it's 30, it is elevated. The bicarbonate is elevated ማለት, there is some sort of metabolic alkalosis, and it tells you the chronicity of the problem. And this lady came with worsening of shortness of breath. She was hypoxic, right? She was hypoxic. She was in respiratory failure, hypoxemic respiratory failure. Actually, we have to modify our diagnosis later on. We have to say that the patient is in acute on chronic hypoxemic respiratory failure secondary to congestive heart failure. That's going to be the right diagnosis. She came with desaturation. She came with hypoxemia, 89% of the saturation. So just in order to compensate for that, there is some, because since she has a chronic respiratory acidosis, the metabolic system is trying to compensate by resulting in chronic metabolic alkalosis. That's why the bicarbonate is high. Okay, that's how you should interpret. Random blood sugar is 120. She's not diabetic. It's normal. Liver function test, mild elevation, AST/ALT almost 2 times elevated. Total and direct bilirubin are normal. Lipid panel is normal. Okay, what other investigations are missing actually cardiac or as part of cardiac workup? What do you want to add? እየነገርኳችሁ ነው። አትሊስት አንብቡ።
Just X-ray we can check if there is.
ኧረ የምጽፈውን አንብቢ እህቴ፣ ተይ የምጽፈውን አንብቢ። በህግ አምላክ የምጽፈውን አንብቢ፣ ስለ ጉረትሽ አምላክ። Troponin has to be, because she was complaining of some sort of like shortness of breath. None of you mentioned ischemic heart disease actually, because one reason why patients may develop congestive heart failure is because of ischemic heart disease. You didn't mention it. I like it because you consider the epidemiology. So the age of the patient is 35. She's female. She is low risk for, and she's not a smoker. She doesn't drink alcohol. The only risk factor she has is, hypertension. So the other things, she has a very low risk for coronary heart disease. እሱ ገብቷችኋል ብዬ ነው እንግዲህ እኔ መወስደው ፖዚቲቭሊ ነው የወሰድኩላችሁ። You didn't thought of ischemic heart disease. And the fact you are reluctant to mention troponin for that reason, okay, but always make sure that there is no ischemia because it's potentially treatable, it's potentially a killer. So troponin has been checked, it was normal. Even if it is elevated, I wouldn't be surprised. Most probably it's demand ischemia. So the type 2 ischemic heart disease now. It's a demand ischemia. Demand ischemia means there is an imbalance between the need for oxygen and the supply of oxygen ማለት ነው። Supply እና need mismatch ነው demand ischemia ማለት። So troponin could be slightly elevated. Okay? እንደውም ኖርማል ከምል slightly elevated ልበልና ኖርማል ልበለው፣ ሌላ ዲፈረንሻል ላለመጨመር። Then still a possibility, demand ischemia. So you have to say that there is troponin elevation as a result of demand ischemia. And the other test is pro-BNP, pro-BNP or BNP. That's significantly elevated. Let's say 4,500. Significantly elevated. Okay. What does that tell you? What does that tell you?
fluid overload. and
full
especially
overload ወይም ኮንጀሽን ነው የሚነግረን ፕሮቤንፒ 4500 መሆኑ። ከዛ ቸስት ኤክስሬ ብለናል፣ እህታችን ብላለች፣ ኢኬጂ ብለት መስራት እንችላለን። and then the other tests are echo and abdominal ultrasound at least because the patient has all those symptoms። አሁን ቸስት ኤክስሬውን ዲስፕሌይ ያደርጋለሁ። ፓቶሎጂውን ባጭሩ የሚነግረን ምን እንደምታይ ቶሎ ቶሎ አለው አልሄድኩም። ትንሽ ስትሬች ላድርግ ብዬ ነው። ደከመኝ። ዜክስ ኤክስፕሌን አድርግ።
አለው so cardiac there is cardiomegaly first finding cardiomegaly አለ because the cardiac width is greater than 50% of the chest diameter. ሌላ because በደንብ አይታየኝም ግን there might be batting appearance የሚባለው
ባሮ እያሳየው ነው። what has happened to the left heart border?
blunt እንትን ሆኗል what's the term?
straightened ሆኗል አይደል? straightening of the left heart border, right? ከእንደገና እዚህ ጋር ስትመጣ ደግሞ ምን ስንት ሻዶ ታያለ? ይሄን የዚህ አይነት ዴንሲቲ ነው የምታየው ወይስ ሁለት የተለያዩ ዴንሲቲዎች ነው እዚህ አካባቢ የምታየው? ሁለት የተለያዩ ዴንሲቲ so the double density sign የሚባለው ማለት ነው። በኋላ ራይት ተርሚኖሎጂ ኔክስት ስላይድ ላይ አለ። what has happened to the carina?
The carina is no
the carina angle seems a little bit widened አይደል? የሰፋ አይመስልም? and that happens when there is left atrial enlargement. left atrial enlargement መኖሩን በምን አውቃል? straightening of the left border ነግሮሃል። ደብል ዴንሲቲ ሳይንም የሌፍት አትሪያል ኢንላርጅመንት ነው የሚነግር። ሌፍት አትሪያል እንትን ራይት አትሪየም ነው ኖርማሊ ራይት ሃርት ቦርደርን አውትላይን የሚያደርገው፣ ግን ሌፍት አትሪየሙን በጣም ኢንላርጅ ሲሆን ያው እዚህ ድረስ መጥቷል። ለዛ ነው ደብል ዴንሲቲ ሳይን የሚታየን ማለት ነው። ሁለት ቦርደር ያለው ይመስላል ራይት ሃርት ቦርደሩ እና ስለዚህ ካራይናውንም ሌፍት ሜን ስቴም ብሮንከሱንም ጌትስ ፑሽድ አፕዋርድስ። ለዛ ነው የካራይናል አንግል ሞር ዛን 70 ዲግሪ ይሆናል። አንዱ ሌላው ኢንዳይሬክት ሳይን ነው። ሌላስ ምን ታያለ? ላንጉ ላይ
ባት ዊንግ አፒራንስ ነው የሚሉት
ባት ዊንግ ወይም ደግሞ ሴፋላይዜሽን አይደል? ሴፋላይዜሽን ማለት ምን ማለት ነው? ሴፋላይዜሽን ሚንስ ሪዲስትሪቢዩሽን ኦፍ ዘ ፕሉመናሪ blood flow to the upper lobe ማለት ነው። so whenever there is like pulmonary hypertension ምናምን በሚኖርበት ጊዜ there will be redistribution of blood flow to the upper lobes እና you can see prominent vasculature in the upper lobes እና ስም አለው I don't remember the exact term bullshit እና reversed mustache sign ይባላል። አይመስልም? የህንዶቹ ሙስታሽ አይመስል ወደ ላይ የተቀለበሰች ሙስታሽ reversed mustache sign ወይም ሌላ ስም አለው። I will explain that to you እና መልቲፕል ኤክስሬዎች አሉን እና ስለዚህ ሴፋላይዜሽን መኖሩ ደግሞ ምንድነው የሚነግረን? together with the presence of crackles in the lung examination it tells you that there is pulmonary congestion አይደለ? ራፕ አፕ እናርገው እና there is ሴፋላይዜሽን antler sign ነው የሚባለው ወይም upturned mustache sign ይባላል። shadow in shadow ወይም double atrial shadow ነው የሚባለው። ከርሊ ቢ ሳይኖች ደግሞ አሳያቸዋለሁ። ከርሊ ቢ ሳይንስ የሚታዩት ኮስቶፍሬኒክ አንግል አካባቢ ነው። ዲቱ ቲክንድ ኢንተርሎቡላር ሴፕታ ነው እና እነዚህ ፋይንዲንጎች most of the time they are seen in patient with mitral stenosis actually እና the right heart border ደግሞ can be shifted to the right indicating right atrial dilatation secondary to pulmonary hypertension and right ventricular hypertrophy ማለት ነው. So it looks like this patient has all those signs. And now you see these lines, the horizontal lines here, you see them here. So those are like the curly B lines, and that's due to mitral stenosis. It's very common in mitral stenosis patients. So እዚህ ጋር በደንብ ይታያል። አኦርቲክ ነክሉ ይታያል። the pulmonary artery prominent ከሆነ 3 bumps ይባላል። 1 bump here, the second bump due to prominent pulmonary main pulmonary artery, and the third one is due to enlarged left atrial appendage or left atrial enlargement. እና straightened ይሆናል. and this is the left ventricle ማለት ነው። እና the left heart border is straightened and it has 3 bumps. And that tells you when the pulmonary artery is prominent, it tells you that there is pulmonary hypertension, and the pulmonary hypertension is due to left-sided valvular heart disease ማለት ነው. And the apex is also shifted. As you can see, it's very shifted. Laterally displaced ነው። ካርዲዮሜጋሊ ያለ እንዳልከው more than 70%. ይሄ ሌፍት አትሪያል ነው፣ ሌፍት አትሪየም ነው። ይችኛዋ ደግሞ ራይት አትሪየም ናት። that is ነው shadow in shadow፣ ሁለት double shadow sign ማለት ነው። double density sign የሚባለው one density here, different density here, double density sign የሚባለው in the right border. So it's very typical X-ray signs ናቸው። ይኸው እዚህ ጋር and the carina is pushed up. You can clearly see the carina is pushed up. The carinal angle is big, and you can see the left atrial appendage, red arrow, and left arrow shows you the boundary of the enlarged left atrium, and the white arrow shows you the right atrial border. እና shadow in shadow, one shadow here, another shadow here, shadow in shadow ወይም double shadow sign ማለት ይሄ ነው። Okay. I brought multiple X-rays so that you can understand them, the findings better. እዚህ ጋር description አለ, you can read it by yourself. እና ካራይናል አንግሉ more than 90 ዲግሪ ይሆናል ያለው ይሄንን ነው። እንደዚህ ፑሽድ ስለሚሆን ብልቅጥ ይላል ማለት ነው። ኖርማሊ አኪዩት መሆን ያለበት ሞር ኦብቲዩስ እንዲሆን ይደረጋል because the left atrium is pushing the left mainstem bronchus upwards. Straightening ማለት ይሄ ነው። ሴፋላይዜሽን የምንለው ደግሞ ይሄ ዋይት ሰርክል ያለበት prominent hilum and prominent vasculature, especially in the upper lobes ማለት ነው። ደብላ ይሄ ዋይት አሮ የሚያሳያችሁ የሌፍት አትሪየሙን ባውንደሪ ነው። የራይት አትሪየሙ ባውንደሪ ይሄ ነው። አንድ ሻዶ አለ እዚህ፣ ሌላ ሻዶ እዚህ ጋር አለ። ሻዶ ኢን ሻዶ ወይም ደብል ሻዶ ሳይን ማለት ይሄ ነው። These are very common findings in patients with mitral stenosis. Okay. And what do you see here? The white arrows, the yellow arrows. ምንድን ነው የሚያሳዩት? What is that? And something we may be able to see in our patient. What is that?
Valvular calcification.
Valvular calcification, excellent. So this is the area of the mitral valve. You can see my mitral valve annular calcification is calcified already here. It's very common in patients with like chronic rheumatic heart disease. So you shouldn't be surprised if you see that. All right, so multiple X-rays from different patients to demonstrate what are the possible findings on chest X-ray. You may be able to see all these things on chest X-ray. Guys, don't leave. So እየተመናመናችሁ ነው። ቶሎ ጨርሳለሁ በቃ ነው እንዳትሰላችሁ። Spot diagnosis on the EKG. On the EKG, what do you have on the EKG? Is it a regular rhythm? So whether it's regular or not, you have to look into lead to ነው። ይሄ what lead to ስለሆነ lead to ላይ ፎከስ አድርጉ። Is it regular? ስታዩት ፐልሱ አር ኢንተርቫሉን ተመልከቱ ማለት ነው። ከአር እስከ አር ያለውን ስታዩ is it regular or irregular?
Irregular QRS complexes with
Yes.
non-discernible P waves.
Excellent. So you cannot see the P waves. There is no P wave. You are right. Excellent. You can't identify the P waves. P wave is absent. Plus the the R to R interval is like, irregular, erratic. So what's going on?
Atrial fibrillation.
Atrial fibrillation. Yeah, atrial fibrillation. There is no P wave. You don't see any P wave. Do you see? You see the QRS complex? You see the T waves, but there is no P wave. You see QRX? You see T waves? There is no P wave here. QRS is here. There is no P wave. QRS አለ, T wave አለ. So you cannot identify P waves. P waves are absent. Plus it's irregular. So we are dealing with atrial fibrillation. And of course, we kind of guessed based on physical examination. She has irregular pulse, plus her heart rate is 110. So her heart rate is no control. So we call it AFib with RVR. Actually, it has to be more than 120, I think, to qualify as RVR or uncontrolled rate. Rapid ventricular rate ማለት ነው RVR. So the next investigation should be echo and abdominal ultrasound. So echo would diagnose, right? So echo would give you the definitive diagnosis. Up to now, you know, physical examination in picking a murmur, sensitivity up to 70% to sensitivity up to 98%, 95% ይሆናል ይባላል. So based on our physical examination, we are suspecting multivalvular heart disease, but eventually the final diagnosis has to be made by doing echocardiography. At least we have to do transthoracic echo. So echo findings: severe MR, severe MSCR, severe TR is confirmed, very thickened mitral valve leaflet cell scene, ejection fraction is 35%, moderate to severe pulmonary hypertension present. So let's talk about our final diagnosis. Let's put a final diagnosis. So tell me, rephrase your diagnosis now. What's your final diagnosis? At least rephrased. ነገርኳችሁ እኮ acute on chronic hypoxemic respiratory failure secondary to multivalvular heart disease, and particularly multivalvular heart disease due to chronic rheumatic heart disease. So we have got TR, severe TR, MR, and MS. Do you agree with this? Acute on chronic hypoxemic respiratory failure, secondary to multivalvular heart disease due to chronic rheumatic heart disease, particularly TR, MR, and MS. Does that make sense?
Yes, it makes sense. One question only. Do we have to mention the presence of a congestive heart failure in this situation, or the respiratory failure secondary to multivalvular heart disease will suffice?
No, you should, because like, you know, if you simply say like, you know, acute on chronic hypoxemic respiratory failure due to multivalvular heart disease, it doesn't tell me whether the patient is in decompensated heart failure or not, you know? She may have like, you know, a compensated heart failure. She might have been diagnosed with heart failure in the past, but you know, it could be compensated right now. So right now it's decompensated. Actually, I have to add decompensated congestive heart failure. Acute on chronic hypoxemic respiratory failure secondary to decompensated. Actually, decompensated, thank you for asking, heart failure with reduced ejection fraction. You got the point?
What about the NIHA and the staging? Shouldn't we mention that?
Yeah, you can mention that if I ask. I will ask you about that. But like, you know, right now as a diagnosis, acute and chronic hypoxemic respiratory failure, secondary to decompensated heart failure with reduced ejection fraction. And the underlying pathology is multivalvular heart disease due to chronic rheumatic heart disease. Okay? You know, አንዱ ከአንዱ የተወሳሰበ ስለሆነ ብዙ መሰለ እንጂ this is how you should outline it. Because this lady can have all these findings, but you may say no acute decompensation, especially JVP ባይኖራት, hepatic enlargement ባይኖራት, lower extremity edema ባይኖራት, ascites ባይኖራት, pulmonary congestion ባይኖራት, ምን ባይኖራት, already heart failure with reduced ejection fraction ብቻ ብለህ አልፈህ ግን decompensated አይደለም at least. ግልጽ ነው? That is the reason why you have to say decompensated heart failure. It makes a big difference in terms of management. It tells me also a different story when you are decompensated or non-decompensated. Actively manage ልታደርግ ነው ብዙ ነገሮችን አሁን because she's in decompensated state. ግልጽ ነው? Cardiomyopathy is out. HOCM was not demonstrated on the echo. There was no evidence of dilated cardiomyopathy. There was no hypertrophy and all that. So it's completely, those things are out. We didn't find those things on echo. So now we are dealing with multivalvular heart disease due to chronic rheumatic heart disease. Secondary diagnosis, like we said, congestive hepatic, CKD, cardiorenal, maybe a degree of AKI could be there due to cardiorenal. Cardiac cachexia could be there as a secondary diagnosis. ግልጽ ነው? Do you have questions?
Yeah, doctor, shall we add anemia as a precipitating factor for the
It could be.
chronic
It could
rheumatic?
be. It could be. So what is the precipitating factor? አላወራንም። ልክ ነሽ. Anemia could be one of the reasons why the patient went into decompensation because like, you know, all patients wouldn't develop decompensated heart failure. There must be, you know, precipitating factor, and anemia is one good reason why patients might develop decompensated heart failure. You are right. Pneumonia, any infectious process, increased fluid intake ሊሆን ይችላል, increased salt intake ሊሆን ይችላል, ምንድነው ደግሞ not taking their medications appropriately ሊሆን ይችላል. So you have to look for the reason why this patient actually developed decompensated heart failure at this point. That you have to dig, okay? Additional information is required to see what really precipitated the decompensation. It looks like this patient had this multivalvular heart disease for some time, but what pushed her to decompensated heart failure የሚለውን investigate ማድረግ ያስፈልጋል. And anemia is one good reason. Infection is another reason. And not taking medications appropriately, increased fluid intake ሊሆን ይችላል, increased salt intake ሊሆን ይችላል. That you have to find out. So you can go back and now you can ask the lady whether she has all these risk factors or not. ግልጽ ነው? Whatever the case ግን አሁን now we are dealing with heart failure with reduced ejection fraction and she has hypoxemic respiratory failure as a result of that. So we can put that as a final diagnosis. Principle of treatment እንግዲህ there are medical treatment. I will summarize it myself. You can also read it in detail for yourself at your own convenience because we have taken a long time እና ሁላችንም እኔም የተዳከምኩ ነው። ፋይናል ዲያግኖሲሳችን ይህን እናደርግና principle of treatment summary እንግዲህ the history 35-year-old female patient who has been having respiratory distress over a year, came with worsening shortness of breath, worsening lower extremity edema now. She has signs and symptoms of congestive heart failure. Risk factors identified. You know, as a child, she had multiple incidences of sore throat, most probably with group A streptococcal infection, resulting in acute rheumatic fever and eventually complicated by chronic rheumatic heart disease. On physical examinations, she has all evidence of heart failure. Lab investigations, some derangements have been noticed. We have discussed about them. There were evidence of heart failure. And then we did echo, we did X-ray findings, very typical of cardiomegaly, signs of left-sided heart failure, signs of pulmonary hypertension present. And echo also confirmed the presence of pulmonary hypertension. And the hypoxemia can be explained by, you know, by worsening of the pulmonary hypertension as well. And principle of treatment, you have to admit this patient to cardiac ICU, you have to continue oxygen supplementation, and then you should start them on last 6 drip, you know, because, you know, sometimes giving boluses of, boluses of diuretics may not be effective. Diuretics has a central role because it results in a very significant symptom improvement. And now most of the time we tend to put them on last 6 drip, and you have to continue monitoring renal function. Electrolyte derangement has to be continuously monitored. A patient has to be on telemonitoring because she is a patient known to have atrial fibrillation. You have to see whether the patient is going to convert into sinus rhythm or if the patient is developing, AFib with RVR or rapid ventricular response, or if a patient develops any dangerous arrhythmia like VTAC, ventricular tachycardia and everything, you can easily diagnose it. Patients may be prone to develop torsades pointus, which is a focal, it's, if a patient with torsades may eventually precipitate into ventricular fibrillation, and they may develop sudden cardiac death. She's at a very high risk for sudden cardiac death. She has a very reduced ejection fraction. So strict IOS has to be monitored. Daily weight monitoring is very important. You have to restrict fluids to less than 1.5 liters over 24 hours. Low sodium, some people say less than 3 grams within 24 hours. Some say less than 2 grams within 24 hours. Anticoagulation, mainly because this is a lady with atrial fibrillation. She has enlarged left atrium, enlarged left atrial appendage. So she is prone to develop, clot formation within the left atrial appendage, and she may end up, developing stroke. So in order to prevent a stroke, we have to put them on anticoagulation. So I have to put them on Coumadin, warfarin, or any of the DOACs, this direct oral anticoagulants like Xarelto or Apixaban, okay? And amiodarone or digoxin is very important in this lady because, amiodarone, most of the antiarrhythmic medications are dangerous in patients with heart failure because they are pro-arrhythmic. They may induce arrhythmia, especially class 1, class 3 የሚባሉት እና ሶታሎል ምናምን የሚባሉት antiarrhythmic medications, they could be dangerous. So they should be avoided. And amiodarone may be used if a patient develops RVR, rapid ventricular response, and you cannot control the rate. You can put them on amiodarone. In our case, people use digoxin. Here, you don't usually use digoxin. The advantage of digoxin is if a patient has cardiac cardiogenic shock, it has a positive inotropic effect. So you can use digoxin. It can control the rate. At the same time, it can also augment on the contractility ማለት ነው. You have to monitor electrolytes because you are putting the patient on Lasix drip. The patient may develop hypokalemia, and she's borderline the potassium of 3.6. So you have to monitor the potassium. Magnesium has to be maintained above 2. Potassium has to be maintained at least more than 4 to avoid any arrhythmia, okay? Because these patients are prone to arrhythmia. And consider ICD placement to prevent sudden cardiac death. So either primary prevention, or if a patient has already developed, cardiac arrest, they get resuscitated and they recover from that. They may need ICDs to prevent secondary or primary sudden cardiac death. Okay, this is implantable cardiac defibrillator ማለት ነው። እና ኢትዮጵያ ብዙም I don't think it's available, but here for patients with significantly reduced ejection fraction, especially if the ejection fraction is less than 30, እዚህ 35 ምናምን ነው ያልነው. I think I have to change the ejection fraction so that should qualify for ICD placement. echo galid እና finding ልቀይረው. Her ejection fraction, let's say it's 25%. So it's indicated in this patient to place ICD to prevent sudden cardiac death. Nahom, I will answer your question. I have seen it. Just keep it there so that I will ask you. I don't አታውረደው እጅህን። ከዛ ሜዲኬሽን አለው guideline directed medical therapy. I'm not going through this. This is available and up to date. You can also read it at your own pace. There are medications. So renin-angiotensin inhibitors ወይም ኔፕሪሊስን ኢንሂቢተርስ የሚባሉት ኢንትረስቶ የሚባል አሁን በጣም ውድ መድኃኒት ነው። ሳክሩቢትል እና ቫልሳርታን ኮምቢኔሽን ነው። ይሄን ኔፕሪሊስን ኢንሂቢተር ነው ሳክሩቢትል፣ and valsartan as you know is angiotensin receptor blocker ነው. So it's a very famous drug. It really has impact on mortality and all that. You can also use AC inhibitors or angiotensin receptor blockers. The cardiac remodeling effect አላቸው, mortality effect አላቸው. So patients have to be started on AC inhibitors or ARBs. Once they tolerate AC inhibitor or angiotensin receptor blocker, you can put them on this sacubitril valsartan or trade name Internist ይሉታል. Beta blockers, you can put them on beta blockers, but you have to be really careful. አንደኛ beta blockers shouldn't be started until a patient is euvolemic. Volume overload and manage እስክናደርግ don't put them on beta blockers. And plus, if a patient is like, bradycardic or if they cannot tolerate beta, or if they are in a florid heart failure, the beta blocker might exacerbate your heart failure. But beta blocker can help you also control the heart rate, since this patient has atrial fibrillation. So Coreg is famous, bisoprolol or metoprolol 6-unit or metoprolol የሚባለው. These are very famous, you know, and they do also have mortality benefit አላቸው ማለት ነው. So beta blocker, angiotensin receptor blocker, AC inhibitors, these are part of guideline directed medications ናቸው። እነዚህ primary pharmacologic therapies ናቸው for heart failure with reduced ejection fraction. የሚቀሩ አሉ። ሌላው mineralocorticoid receptor antagonistoች ናቸው, especially if the patient's ejection fraction is less than 40, you have to put them on either or spironolactone or eplerenone. So these are very important medications as well for reduced ejection fraction heart failure. And the sodium glucose co-transporter inhibitors, these are also new medications, dapagliflozin, empagliflozin. They are being advocated these days for heart failure management with reduced ejection fraction. Mortality benefit እንዳላቸው ነው studies የሚያሳዩት. So you can add SGL2 inhibitors. So these are the guideline directed medical therapies, primary treatmenቶች ናቸው. Beta blocker, AC blocker, AC inhibitors or versus ARBs እና beta blockers እና SGL2 inhibitors. And the other is diuretic. Obviously the diuretic helps you with symptomatic management. Mortality, minimum mortality benefits. And secondary pharmacologic therapies, they are alternatives if your patients cannot really tolerate those medications I mentioned as a primary means of treatment. You can think of this isosorbate dinitrate plus hydralazine. So they can manage hypertension. They can also manage angina symptoms. Isosorbate dinitrates, hydralazine fixed dose combination, evadrabine, I don't know these medications, and digoxin. I also mentioned digoxin. That's, you know, rarely used, especially in the West. Medications to avoid, there are certain contraindicated medications in florid heart failure. Glucocorticoids, non-steroidal anti-inflammatory drugs, which are very famous in Ethiopia. We use them right and left. Avoid them in patients with heart failure. Why they should be avoided? They tend to advocate or they precipitate sodium retention. ስለዚህ fluid overload ይኖራል ማለት ነው። they worsen it እና ሌሎችም ሜዲኬሽኖች አሉ. read about them. even diabetic medications like metformin, thiazolidine, diones የሚባሉት እና ሌሎች anti-arrhythmic medications, class 1, class 3 medications pro-arrhythmic ናቸው. so they may precipitate very dangerous arrhythmias like ventricular tachycardias, ventricular fibrillation, and resulting in sudden cardiac death ማለት ነው. so you have to avoid those medications. Further care, you have to obviously, of course, the main management is going to be by heart failure team or cardiology team, and you have to consult cardiothoracic evaluation for cardiothoracic evaluation. Maybe the patient may not be a perfect candidate to undergo surgery at this point, but eventually she definitely needs cardiac surgery for valve replacement. Options of management, surgical intervention. Mitral valve repair is nowadays the one which is advocated, especially this is a young lady, 35 years old, you know, she may need multiple cardiac surgeries down the road, and she wants to have a pregnancy. You know, she was telling you her story. Her husband wants a kid, she wants to have a kid, she's being depressed because she cannot really have children and all that. So they plan to have kids. So if you do, like, you know, mitral valve replacement with mechanical valve, you are, you know, minimizing her chance of having a kid because, you know, you are going to put her on anticoagulation. Some of them, they do have fatal side effect, and some of them that increases also their bleeding tendency during pregnancy or childbirth. And now it complicates the life of this lady. So as far as possible, if it is possible, you try to do mitral valve repair. Unfortunately for this lady, mitral valve replacement is not going. I don't think mitral valve repair would be an option because thickened ናቸው ብሎናል. both regurgitation and stenosis አለው ብሎናል. most probably this lady is not amenable for mitral valve replacement. If it was only mitral valve regurgitation, you know, one might try to do some sort of repair, or if it was a purely mitral stenosis ቢሆን ኖሮ mitral balloon commissurotomy could have been tried. Okay, but now in this patient, I don't think mitral balloon commissurotomy would be an option. This is a percutaneous catheter procedure. No, the only problem is if you do commissurotomy, this lady already has severe mitral regurgitation, and you do commissurotomy, you are going to kill her on the table. She will have fulminant heart failure with pulmonary congestion. You'll kill her on the table. So it's completely out. Balloon commissurotomy for this lady is out. So it looks like this lady is a candidate only for mitral valve replacement. Then the issue is whether to give her mechanical valve versus bioprosthetic valve now. Bioprosthetic valve, I would go ahead and do it with bioprosthetic valve because she wants to give birth. If you give her bioprosthetic valve, at least, you will make her, she will be able to have carry kids, give birth, and now a bioprosthetic valve after a couple of years it degenerates, but eventually you can go ahead and replace it with mechanical valve once she completes her family ማለት ነው. If you give her mechanical valve, then her life as a lady and her plan of having kids will get complicated. I'm not saying patients with mechanical valve and anticoagulation they don't give birth ማለት አይደለም, ግን it complicates their life. It complicates their life. In fact, one of my contacts in LinkedIn asked me a question about this kind of case. He has a relative who has a mechanical aortic valve actually, and she wants to give birth, and she's pregnant. And he was asking me about the warfarin and everything. They were worried about it. Okay. So that's the challenge of giving a mechanical valve for a lady who hasn't completed her family size. In fact, this lady doesn't have even a kid and she wants to become a mother. Tricuspid valve repair is also important for this lady because she has severe tricuspid regurgitation. And most probably, it's either due to involvement of the tricuspid valve by the chronic rheumatic heart disease, which is extremely rare, or it could be a functional abnormality because of right-sided heart failure due to the left-sided heart failure with pulmonary hypertension. And that could be just a functional problem, ሊሆን So you have to do at least ring annuloplasty or apply a ring, tighten it, and that would serve the purpose, I hope. I wish I asked you these questions. I forward these questions to you, but, we took a long time, more than expected. And I don't want to, people are like, the number of attendees is going down, so I don't want you to leave. So that's why I'm explaining everything by myself. But this is at least the principle of treatment and everything. Cardiac rehabilitation is very important because, after heart failure, patients should really have cardiac rehabilitation. And now if the patient is not amenable ለዚህ ለቫልቭ replacement ምንም ተደርጎ ደግሞ if the patient is not really responding to our treatment or if they are not candidates for valvular heart repair ምናምን candidate ካልሆኑ you may even consider a possibility of heart transplantation, which is fancy in our setup, but at least that exists if you have end stage heart failure. And if you think the ventricles are already failed, and even if you do the valve replacement, if you think that's not going to help the patient in any way, then the last result would be cardiac replacement by transplantation. Do you want to do one or two questions, or it's too much? Or you want to try one question at least? Yes or no?
የስ ብንሞክር ጥሩ ነው።
እሺ ሞክሩ። በቃ ይሄን ያህል ከቆያችሁ አይቀር ያን ያህልም አይጨምርብንም። አንድ 5 ደቂቃ ምናምን ቢጨምርብን ነው። ጥያቄዎቹን እንሞክራቸው። ትክክል። አይ ላቭ ዘ ስፒሪት ቴንክ ዩ ሶ ማች ማይ ብራዘር። እኔም እንደናንተ ነበርኩ። እንደዚህ በቃ እንስራ አንሂድ እንደዚህ አይነት ተማሪ ነበርኩ። ዱ ዩ ዋንት ቱ ዱ ዚስ የስ ሌትስ ዱ ኢት እና እንደዛ የሚል ግሩፕ ሳገኝ ደስ ይለኛል። ብሩኬ የጻፍኩልህ ቁጥሮች ስንት ናቸው? ይኸው አገኘሁት። በቃ እስቲ አንብቡ። አንድ ሰው አንብብና መልሱ።
አይታይም ዶክ ሪሼር አድርገው አይታይም።
ኦ አይታይም። ኦኬ እሺ። አየህ እንዳንተ አይነት ጀግና ኮሆስት የሚያስፈልገኝ ለዚህ እኮ ነው። Okay, new share ማድረግ አለብኝ ልክ where is it? Do you see any mix up? Question board ታያቸዋል? Okay.
ዶክ ወይ ስቶፕ ሼሪንግ ብለኸው
አድርጌያለሁ እኮ ስቶፕ ሼር አላልኩም?
አላልክም። አሁን እኛ ጋር ስቲል ስላይድ ነው የሚታየው።
እሺ ስቶፕ ሼር ከዛ ሪሼር
የናሁም ጥያቄ አለ እጁ እስካሁን ላይ ነው።
እሺ እጁ ተንጠልጥሏል ወንድማችን። እግዚኦ 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 በል አውረድ እስኪ ጠይቀንና አውረድ እጅህን።
እሺ ኧረ ችግር አልነበረውም። እኔ እንትን አንድ ጥያቄ ነው ያለ ሁለት ጥያቄ ነው አክቹዋሊ ትንሽ ዲፕ እንዳይሆን ፈራለሁ። ግን የመጀመሪያው ጥያቄ አንታይ ኮአጊሌሽን ላይ እንደ በፕራክቲስ እና ናሽናል ጋይድላይን ላይ ፎር ፔሸንትስ ዊዝ ማይትራል ስቴኖሲስ ኦንሊ ዋርፋሪን ኢዝ ሪኮመንድድ ይላል እና ዋይ ዛት እና እሱ ላይ ኮመንት ካለ
ትክክል ነህ ጎበዝ። በጣም አሪፍ ጥያቄ ነው። ይቅርታ አድርጉልኝ ቅድም እነዛን ዶዋክስን በመግለጼ ማለት ነው። Because like, you know, for atrial fibrillation related to any valvular heart disease, the one which is extensively researched and the one which is found out to be effective and safe is warfarin. So the DOACs, we don't have enough data whether they can be used for atrial fibrillation related to valvular pathology. Excellent question. I love it, my brother. So you are right. We have to put this patient on warfarin. Thank you so much. This is the reason why we encourage you to ask the questions. Thank you.
The second question is, we decided to put the patient on Lasix drip, and now it is studied that spironolactone has mortality benefit. Now Lasix just symptomatic benefit ነው ያለው እና ፔሸንቱን ክሮኒክ ማኔጅመንት ላይ ሲገባ ላይክ ዲኮምፐንሴትድ ስቴት ወጥቶ ወደ ክሮኒክ ማኔጅመንት ስንገባ what is the way we transition the patient to spironolactone, or we just use double diuretics?
Most probably you use both of them. You put them on Lasix and you put them on spironolactone, both of them. And spironolactone is given for those patients, like I said, most of the time when the ejection fraction is less than 40%. That's one of the indications to put them on aldosterone receptor blockers, which is spironolactone.
Okay, so ejection fraction indication ካላሟላ አንሰጣቸው ማለት ነው።
አትሰጥም። You don't need to give them spironolactone. That's part of the management of heart failure with reduced ejection fraction. And yeah. So double diuretic ላይ ታደርጋቸዋለህ። አሁን ግን acutely እቺ ሴትዮ fluid overloaded ናት. So you have to manage her with loop diuretics. እና ላሲክሱም የማይሰራ ከሆነ ቢሜክስ ምናምን ላይ ሌላ ያልሰራናቸው ኢንቨስቲጌሽን አሉ። እናንተም ያልጠቀሳቸዋቸው ዩሪናሊሲስ መጨመር አለበት። Don't forget, because you were talking about like, you know, nephrotic syndrome. So you have to see whether there is, you know, proteinuria or not. ከዛ ፕሮቲን ዩሪያ መኖሩን ደግሞ ካረጋገጣችሁ you have to do urine protein to creatinine ratio. So over 24 hours ምን ያህል gram of protein lose እያደረገች መሆኑን that's how you diagnose nephrotic syndrome አይደለ? more than 3 gram over 24 hours አይደለ? ስለዚህ you didn't do that investigation. So UA is part of the investigation. Don't forget that, okay? I just remembered now. Okay, ማን ነው መስራት የሚፈልገኝ ጥያቄ አንብቡት ቶሎ በሉ። ስለደከመኝ ነው እንጂ አነብላችሁ ነበር። I'm tired. So just read and answer this question. Zex አንብብ.
A 27-year-old woman is hospitalized for a one-day history of orthopnea and PND. She delivered a healthy baby boy 6 days ago. She is breastfeeding. On physical exam, blood pressure is 134 by 78 millimeter mercury. Pulse rate is 98. Respiratory rate is 26. Oxygen saturation is 94, with the patient breathing ambient air. There is jugular veins distension and an NS3 gallop. S3 sound one. Crackles are heard about halfway up the lungs. There is low extremity edema to the knees. Laboratory studies show an elevated B-type natriuretic peptide level, a normal high sensitivity troponin less than 99% percentile above reference limits, and a serum creatinine level of 1.2 milligram per deciliter. Chest radiography shows pulmonary edema. Echocardiogram shows an ejection fraction of 20% and diffuse hypokinesis. Intravenous furosemide and bi-level positive airway pressure are initiated.
BiPAP ማለት ነው BiPAP ማለት ነው because she's in congested, she's in hypoxemic respiratory failure. በኦክሲጅን ሪስፖንድ የማታረግ ከሆነች ሴትዮ have to put her on BiPAP. That means you have to supplement with positive airway pressure ማለት ነው. So ያቺ አሁን የኛም ፔሸንት ኦክሲጅን ላይ አድርገናታል ሪስፖንድ ባታረግ we have to put her on BiPAP. Okay, don't forget. That's one part of the reason why you have to admit this patient to ICU. Okay, go ahead. Non-invasive ventilation ማለት ነው. So which of the following is most appropriate additional treatment? Bisoprolol is beta blocker, diltiazem is a calcium channel blocker, non-dihydropyridine ከሚባሉት መካከል ነው. Enalapril is ACE inhibitor. Ivabridine ምንድን ነው? Ivabridine antiarrhythmic ነው መሰለኝ. What is ivabridine?
It's sodium funny channels, የአትሪያል ፔስሜከሮች አክሽን ፖቴንሻል ላይ ሃርት ሬት ለመቀነስ ነው ሜንሊ አይ ገስ እና ፔሸንት ፐርሲስተንት ታይካርዲክ ከሆነና ሃርት ሬቱን መቀነስ ከፈለገ ፈኒ ቻናሎችን ብሎክ ያደርግልንና አውቶማቲሲቲውን ትንሽ ቀንሰዋል።
እሺ, so which treatment do you want to start on this patient?
እሱኛው ዲ
Ivabridine. ሌላ ሰው
Enalapril maybe.
Enalapril ሌላ እሺ ቦት አድርጉት።
Keratin 1.2 ነው it may be.
That's fine, it's borderline ነው.
Almost.
ምረጡ C D A B እስ ኮመንት አድርጉ። የሚበዛውን ልይና ልንካ ሲ እያሉ ነው። አንድ ሰው ሲ ከጨመረ እንትን እላለሁ። ኦኬ so Enalapril. Yes, you guys are perfect. So the answer is C. ምክንያቱም ምንድነው ACE inhibitors reduce morbidity and mortality in patients with heart failure with reduced ejection fraction and should be used both in symptomatic as well as asymptomatic patients. Metoprolol, carvedilol, and bisoprolol reduce mortality in patients with heart failure with reduced ejection fraction, but treatment should be delayed in patients with volume overload until the patient is closer to being euvolemic. ቀደም ያልኳችሁ ነገር ማለት ነው. That's why bisoprolol መልስ የማይሆንበት ምክንያት ማለት ነው. ስለዚህ Enalapril ጋይድላይን ዳይሬክትድ ሜዲካል ቴራፒ። ይቺ ሴትዮ ግን ሃርት ፌሊየሯን ያመጣው ምን ይመስላችኋል?
Peripartum cardiomyopathy maybe.
It looks like it. Yeah, it looks like it. 6 ቀኗ ነው ገና ከወለደች አይደል?
Yeah. So within the 6 months, 5 months the common.
Yeah. ይችን መልሱና we will call it a day.
አንብብ
አንብባ ፈርዶብሃል።
A 67-year-old woman is evaluated during a follow-up visit for heart failure with reduced ejection fraction. She reports stable dyspnea with exertion when carrying groceries from her car or walking up a hill. She has no other symptoms. Medications are carvedilol, spironolactone, maximum dose lisinopril, dapagliflozin, and furosemide. On physical exam, blood pressure is 108 by 72 millimeter mercury and pulse rate is 60. The remainder of the examination is unremarkable. Laboratory studies reveal a serum creatinine level of 1.3 milligram per deciliter. Previous echocardiogram shows left ventricular ejection fraction of 67%. Which of the following is the most appropriate treatment?
I think maybe adding digoxin.
Adding digoxin, okay.
Because she has stable dyspnea and as well as reduced ejection fraction. It might have some benefit for those symptoms.
Okay. What else? Remember, I said digoxin is rarely used here. And this question comes from a US system. So let's...
switching them have to Arnie.
Huh?
D.
D, excellent, because we have been talking about Intrasto, right? Intrasto at this now. It's a combination of lisinopril and switch lisinopril ቀይረን ወደ valsartan sacubitril. A combination is much more effective ተብሎ ይታሰባል than a single ACE inhibitors or ARB. This is a angiotensin receptor blocker. This is nacrolipsin inhibitor now. So mortality benefit አለው as compared to the others. So this is the answer. So valsartan sacubitril significantly reduces heart failure, hospitalization ይቀንሳል, mortality ይቀንሳል in patients with symptomatic heart failure with reduced ejection fraction, and is recommended in preference to ACE inhibitor or angiotensin receptor blocker ማለት ነው። ግልጽ ነው። ዲጎክሲን ለምን አይሆንም? ኤን እንመልከው። Digoxin reduces the risk of hospitalization for heart failure but does not affect mortality. That is a problem. Digoxin toxicity is common. That's another problem. And risk is increased in patients with abnormal renal function. She has abnormal renal function, as is the case with this patient. It may be helpful in patients with heart failure with reduced ejection fraction who have concomitant atrial fibrillation, just like that of our patient, to aid in the rate control ማለት ነው። valsartan sacubitril is better option in this patient without atrial fibrillation and with abnormal renal function. That is the problem with digoxin. አንደኛ because of increased risk of toxicity of digoxin in creatinine in 1.3 ነው, and plus there is no atrial fibrillation. ስለዚህ የሬት ኮንትሮል አድቫንቴጁ የለህም። ስለዚህ it's better ከእንደገና ደግሞ mortality benefit የለውም digoxin. So it's better to switch to the combination of valsartan and sacubitril. They call it Internist trade name እዚህ ሀገር ያለው trade name ማለት ነው። በቃ I think ጎበዞች ናችሁ። አንድ ላስት question ልጨምርላችሁ። እኔም ያለኝ ሶስተኛ ጥያቄ ነው። ብዙ ጥያቄ አለ ግን ሬሌቫንት ለኛ ለዛሬ ዲስከሽናችን የሆኑትን መርጬ ነው። እሷን እንስራና በቃ ተሰነባብተን እንለያያለን። እስቲ ደግሞ ሌላ ሰው አንብቡ። ዜክስን አታንገላቱት። እንግዲህ ናሆም አንብብ። ዩኒቨርሲቲ ኦፍ ጎንደር።
እሺ 47-year-old man is evaluated for management of heart failure with reduced ejection fraction. Ejection fraction is 30. Diagnosed 3 years ago. He has New York Heart Association functional class 3 symptoms and has been stable for the past year. His medical history also includes ACE inhibitor-induced angioedema, spironolactone-induced gynecomastia, and atrial fibrillation. An implantable cardioverter defibrillator is in place. Medications are losartan, carvedilol, empagliflozin, furosemide, and apixaban. On physical examination, blood pressure is 120 by 68, pulse rate is 78 and irregular. Other than an irregular heart rhythm, the remainder of the examination is normal. Serum creatinine and electrolyte levels are normal. What is the most appropriate treatment?
እስቲ ሴቶቹ የት ሄዱ? ማን አባረራችኋቸው እንደ እናንተ ሰዎች? ዜክስ እህቶቻችንን አባረራችሁ ነው ምንድነው? ማህሌት ኤፍራታ ምናምን አላችሁ። ማዛ ሞክሩ፣ አይዟችሁ። ብትሳሳቱም አትሳሳቱም እርግጠኛ ነኝ። ብትሳሳቱም ይዳዝም ማለት የት አባቱንስ እና እዚያ አይታረምም። ይሄ ምን እናድርግ ለዚህ ፔሸንት? አሁን እዚህ ላይ የምታዩት ኤሲ ኢንሂቢተር ኢንዲዩስድ አንጂዮኤዴማ አለው ይላል። ስፓይሮኖላክተር ኢንዲዩስድ ጋይኖኮማስቲያ አለው ይላል። አትሪያል ፊብሪሌሽን አለው ይላል። አይሲዲ አለው ይላል። ስለዚህ ሎዛርታን፣ ኮሬግ አንጂዮቴንሲን ሪሴፕተር ብሎከር ላይ ነው፣ ኮሬግ ላይ ነው። እንደገና ደግሞ ኤስጂኤል2 ኢንሂቢተር አለው፣ ፍሩሳማይድ አለው፣ አፒክሳባን አለው። አትሪያል ፊብሪሌሽን ስላለው ነው አፒክሳባን። ሞስት ፕሮባብሊ ነን ቫልቩላር አትሪያል ፊብሪሌሽን ስለሆነ ነው አፒክሳባን ላይ ያደረጉት እንጂ ቀደም በተባለው ሪዘኒንግ ዋርፋሪን ላይ ነው የሚሆኑት። እና ምን እናድርግ ለዚህ ፔሸንት? shall we switch to losartan ወደ valsartan sacubitril እንምጣ? shall we switch coreg ወይም carvedilol to metoprolol-succinate? shall we add ivabridine or shall we add eplerenone? eplerenone ምንድን ነው? eplerenone is aldosterone receptor blocker ነው።
ፖታሽየም ስፔሪንግ
ፖታሽየም ስፔሪንግ ዳዩሬቲክ የምንለው ወይም ሜካኒዝም ኦፍ አክሽኑ ደግሞ አልዶስትሮን ሪሰፕተር ብሎከር ነው። ፖታሽየምን ስፔር የሚያደርገው ለዛ ነው። አልዶስትሮን ዳዝ ኢዝ ሪቴን ሶዲየም ነው የሚያደርገው አይደለ? ፖታሽየምን ኤክስኪዩት አድርጎ። ስለዚህ እሱን ለመከላከል ኢፕሌሬኖን እንጠቀማለን። ልክ እንደ ስፓይሮላክቶን ነው። ስፓይሮላክቶን ችግሩ ምንድን ነው? ስፓይሮላክቶን ኢንዲዩስድ እንትን አለው ጋይናኮማስቲያ ዛትስ ቴሪብል ሳይድ ኢፌክት እና ፔሸንትስ ዱ ኖት ላይክ ቱ ቴክ ኢት ስፔሻሊ ሜል ፔሸንትስ ጋይናኮማስቲያ ስለሚያመጣባቸው እና ዚስ ኢዝ ኦልሶ ሜል ፔሸንት። ስለዚህ ምን እናድርግ?
አይ ቲንክ ወደ ፕሌሬኖን መጨመር
ኤክሰለንት። የፕሌሬኖን ልክ ነህ። ሁሉንም እኮ እየወሰደ ነው። ኮሬ ሎዛርታን አለው፣ ኮሬ ቤታ ብሎከር አለው። እነዚህ ሁለቱም አርብ አለ፣ ኤአርቢ ያለው ቤታ ብሎከር አለው። ከእንደገና ፍሩሳማይድ አለው፣ ኤስጂኤል2 ኢንሂቢተር አለው። ሁሉም እየወሰደ ነው። የቀረው ከእንደገና ደግሞ ኢንጀክሽን ፍራክሽኑ 30% ነው። ከ40 በታች ከሆነ አንጂዮቴንሲን ምንድነው አልዶስትሮን ብሎከር መውሰድ አለበት ብለናል። ስለዚህ ይሄ ነው የሚሆነው ሞስት ፕሮባብሊ። እግዚአብሔር ይርዳን እንግዲህ። we are right. So add eplerenone. ሪዝኑ ምንድነው? aldosterone antagonist therapy either spironolactone or eplerenone is indicated in all patients with symptomatic heart failure with reduced ejection fraction and normal kidney function to improve survival. renal functionaቸውም ኖርማል እስከሆነ ድረስ you can add those and that improves survival ማለት ነው። እና ይሄ ሳኪዩቢትሪል ምናምን የማይሆንበት ምክንያት ምንድነው? ሪስክ ኦፍ አንጂዮኢዴማ አለው። ኤሲ ኢንሂቢተር ወስዶ አንጂዮኢዴማ አለው ይላል እና the combination ደግሞ much worse ነው ሪስኩ ማለት ነው። risk of angioedema in the combination in the Internist is much more severe as compared to angioedema to ACE inhibitors. So changing it to losartan, valsartan, sacubitril is dangerous because patient might develop severe angioedema. Okay, እና whole history በደንብ ማንበብ ያስፈልጋል። አንጂዮዴማ ስፓይሮላክቶን እንዳትሉ ደግሞ አውቀው እዚህ ያለው ጋይናኮማስቲያ አለው ብሏቸዋል። ስፓይሮላክቶን ቢኖርም አትመርጡም፣ የፕሌነሩን ነው የምትመርጡት። ስለዚህ አይ ቲንክ 3 ጥያቄ ሰርተናል። ሰምሃው የተወሰነ ያሳየናል። እንግዲህ እግዚአብሔር የተመሰገነ ይሁን። አትሊስት እዚህ ሰዓት ደርሰን ይሄን ለመስራት ችለናል። I know we took a little bit longer time. ያው ቤድሳይድም ቢሆን ዌብሳይት አይደል ስሙ? it's not a tutorial or የአንድ ሰዓት ዲስከሽን የ30 ደቂቃ ዲስከሽን አይደለም። obviously it is going to take longer time because this has to be stimulating your thinking, reasoning and everything. So it's not that I am coming and presenting the case and going. We are dissecting each and every stage. Actually treatment ላይ ዛሬ ብዙ አልጠየኳችሁም unfortunately because time was going and I was like also I was becoming tired. I was talking a lot. ስለዚህ it's interesting ብዬ ገምታለሁኝ። ሐሳብ መስጠት የሚፈልግ ሰው ካለ ስፔሻሊ ቅድም ከየት እንደመጣችሁ ያልነገራችሁ ልጆች ከየት እንደመጣችሁ ንገሩንና እንሰነባበታለን። ማዛ ከየት ነው የመጣችሁ? ቴክስት አድርጊ። መጻፍ ማውራት ማትችል ከሆነ ማህሌት ታፈረ ከየት እንደመጣሽ ንገሪን። ነፃነት እና ደግሞ ሌላ ማን ነው ያለክ?
I'm from Jimma University.
ጅማ ዩኒቨርሲቲ ዌልካም ማዛ። ወደፊትም እንዳትቀሪ ጓደኞችሽንም ቀስቅሺ። እሺ ማህሌት ታፈረ
ከጥቁር አንበሳ ኒውሲቱ ተማሪ ነኝ።
ኤክሰለንት። ባቾችሽን መልሚ እንግዲህ ወደፊት ብቻሽን እንዳትመጪ ጓደኞችሽ ካልሰሙ እንዲሰሙ። ኦኬ ሌላ ነፃነት ከጥቁር አንበሳ። ኦኬ ስለዚህ ዛሬ በእውነት I think it's successful even though like you know the number of participants grew smaller which is fine. አንድ ሰው ጋር ይሄንን ዲስከሽን ባደርግ at least the recording will be there. And number 2, when people realize the importance of these sessions, you know, without advertising, people would ask, when are we going to have the next session? እያላችሁ ራሳችሁ ተጠይቃላችሁ ከተወሰነ ጊዜ በኋላ ብዬ ሆፕፉል ሆናለሁ። እየረዘመ እየደከማችሁ እየሰለቻችሁ ከሆነም እንደ ፊድባክ ለዜክስ ወይ ለእኔም ብትነግሩኝ ቅር አይለንም። so we'll try to find a way to make it shorter ግን እናሳጥረው ከተባለ የእናንተን ተሳትፎ በመቀነስ ነው የሚሆነው ወይም የእናንተ ተሳትፎ በጣም ፈጣን መሆን አለበት። ጥያቄ ስትጠየቁ you have to engage and answer question fast ያለምንም ይሉኝታ ያለምንም ፍርሃት ቶሎ ቶሎ አይዘር ቻት ቦክስ ውስጥ ወይም በድምጽ መመለስ አለባችሁ። እንደዛ ሲሆን ታይም ኤፊሽንት እንሆናለን። እግዚአብሔር ከረዳን የኔም ስኬጁል በሚፈቅደው መሰረት ለብቻ የምችለውን ያህል እጓዛለሁ። ለብቻ ግን አይሆንም። ይሄ ያየሁት ነው። ሰዎች እንመለምላለን ከተለያየ ስፔሻሊቲ ከተለያየ ሰብ ስፔሻሊቲ። ያው ቮለንቲር ሰው ያስፈልጋል። ኖት ኤቭሪባዲ ኢዝ ኮሚትድ እና ቮለንቲር የሆኑ ወንድም እህቶቻችንን አባብለን አምጥተን እየመጡ እንዲያስተምሯችሁ የተለያየ ሰውንም ፐርስፔክቲቭ እንድታዩ ኦፖርቹኒቲውን እንድታገኙ እናደርጋለን። I am liking it because I have the opportunity to talk to Jimma students, Gondar students, Korea Hospital Medical School students, St. Paul Millennium Medical students, Black Lion Medical students. እነዚህ ብቻ ግን አይደሉም። በጣም ብዙ ወደ 17 ሜዲካል ስኩል እንዳለ ነው የምሰማው። ደብረ ብርሃን አለ፣ መደወላቡ አለ። ብሩኬ ያዘ ይሄንን ሌሎችም አሉ። አርሲ አለ፣ ናዝሬት አርሲ ነው መሰለኝ ናዝሬት ወሎ አለ። ሶሪ ወሎ ዩኒቨርሲቲ የመጣ ወንድማችን አለ። እንደው መርሊን የገባው ብዙ አግኝተናል። 1 4 5 ሜዲካል ስኩል ዛሬ ነበረን ሪፕሬዘንታቲቭ። ስለዚህ ዛሬ ያላችሁ ልጆች ለወደፊቱ እንደዚህ አይነት ሴሽን ነበር ወደነዋል ብላችሁ አድቮኬት አድርጉ። ከጠላችሁትም እንዳደርሱ ብላችሁ አባሩ ማለት ነው። አይዘር ኦፍ ዘት ግዛቸው እጅን አውጥታል። እሺ አንተ ዝጋልን እስቲ በአንተ ሐሳብ እንዝጋ።
ይቅርታ እንግዲህ ያው ብዙ ቆይተናል እና ጊዜ እንዳልወስድ ምንድነው ሐሳቡ እንትን ኬዙ እንትን ቢባል እና ኢንፎርም ቢኖር አንብበን ብንመጣ የተሻለ ፓርቲሲፔሽን ይኖራል ብዬ አስባለሁ እና ሜቢ በዛ ወይ ብንሄድ ከዛ ውጭ አም ሶ ሃፒ ፓርቲሲፔት ማለት ነው። በጣም ደስ የሚል ነገር ነው። ፈልገን የማናገኘው ስለሆነ ማለት ነው።
እሺ ግዛቸው በጣም አመሰግናለሁ። በጣም ቫሊድ ፖይንት ነው። በጣም ቆንጆ ነው። ዘ ኦንሊ ቲንግ እንደሱ ማድረግ ዲስአድቫንቴጁ ምን መሰላችሁ? ኬዙን ከነገርኳችሁ አንድ ነገር ብቻ ነው አጥነታችሁ የምትመጡት። ኦፍ ኮርስ ያንን ኬዝ በተመለከተ ፓርቲሲፔት ታደርጋላችሁ። ከዛ ውጭ ግን ማሰብ አትፈልጉም ወይንም ደግሞ ዲፈረንሻል ዳያግኖሲስ ብሎክድ ይሆናል ማይንዳችሁ። እና አሁን ለምሳሌ ዶክተር ግዛቸው ደሴ ሆስፒታል ባስቀምጥህ አዘ ዲዩቲ ፊዚሽያን ቺፍ ኮምፕሌንት ይዞብህ ነው የሚመጣው። ቱሞሮ አይ አም ካሚንግ ዊዝ ሄርት ፌሊየር እና አንብበህ ጠብቀኝ አይልህም ፔሸንት አይደለ? ዩ ኖ ዘ ሆል ፖይንት ነገ ሲኤልዲ ፔሸንት ሊመጣብህ ነውና አንብበህ ቁጭ በል የሚልህ ፔሸንቱ አያስጠነቅቅህም። ድንገት ነው የሚመጣብህ እና ሰርፕራይዝ መሆኑን የምፈልገው ለዛ ነው። ሪሊ ቻሌንጅ ዩርሰልፍ። ዘ ኦንሊ ቲንግ ዞ ከአንተ የወሰድኩልህ አንድ ነጥብ አለ። ቺፍ ኮምፕሌንቱን እንናገራለን። ዜክስ ትስማማለህ?
አይ ግን ከዚህ በፊት እኔም ጠይቄ ነበር እና አንድ በጣም ያስማማኝ ነገር አሁን እኔም ፈተና ድሮ ስፈተን በእኛም ቤተሳይድም ቺፍ ኮምፕሌንት ነበር የሚነግሩ ግን ቺፍ ኮምፕሌንት ቢሆን ብዙ ከዛ ይራቅ አይደለም። በቃ ፕሬዘንት አሁን ካፍ ከተባለ ካፍ አንተን ነው የምንመጣው በካፍ ነው የምንጠብቀው። ግን ያላጠናነውን ያልተዘጋጀንበትን ብሬንስቶርም እያደረግን እዚህ የምናደርጋቸው ሴሽኖች አይ ቲንክ የበለጠ ቫልዩ አላቸው። ያው እኔ እሰማለሁ በአጋጣሚ ግን ቢሆንም ለሌላ ሰው የሚጠቅመው አጠቃቀም ትልቅ ይመስለኛል ብዬ ገምታለሁ። ፖስት ስናደርገው ዩቲዩብ ላይ ግን እናገራለን ኬዙን።
እስቲ ሴቶች እህቶቻችን ምን ትላላችሁ? ኤፍራታ ምን ታያለሽ? ኤፍራታ አልተናገረችም ዛሬ። ከየት እንደመጣሽም ንገሪን። በዛው ሐሳብሽ ምንድነው? ቺፍ ኮምፕሌንት እንናገር ወይስ ሰርፕራይዝ ይሁን?
ሃይ እንዴት አመሻችሁ? እኔ ከጳውሎስ ነው የመጣሁት እና አይ አግሪ ዊዝ ዜክስ ባይናገር ሰርፕራይዝ ቢሆን ጥሩ ነው መሰለኝ ብሬንስቶርም እናደርግ እና ዩቲዩብ ላይ አፕሎድ ስናደርገውም ቺፍ ኮምፕሌንት ብቻ አፕሮች ቱ ጀስት ፔን አፕሮች ቱ ቦዲ ስዌሊንግ ምናምን እያለን ብቻ ፖስት ብናደርገው ጥሩ እንላለን። ለላይቭ ሴሽኑ ግን should be a surprise I think።
በጣም ጥሩ በቃ እንደዛ እናደርጋለን። ያው አውት ተሳታፊ ቁጥርን ለመጨመር እና እዚህ አክቲቭሊ ኢንጌጅ ማድረግ እና ሪካርዲንግ መስማት ባይዘይ ምን አደከመኝ ሪካርዲንጉን እሰማዋለሁ የሚሉ ልጆች ተሸውደዋል ባይዘይ። ምክንያቱም the will miss ራሳቸውን ቻሌንጅ የሚያደርጉበትን ኦፖርቹኒቲ፣ ሀሳባቸውን የሚሰጡበትን ኦፖርቹኒቲ፣ ፊድባክ የሚያገኙበትን ኦፖርቹኒቲ፣ ራሳቸውን ኤክስፕሬስ የሚያደርጉበትን ኦፖርቹኒቲ ሁሉ ነው ሚስ የሚያደርጉት። it's a very golden opportunity by the way። እና ይሄን ፊድባክ አሁን ላይ ብታገኙ you will be a better physician clinician ከእንደገናም ደግሞ as a student as a candidate in exams you would do really excellent amazing job ታረጋላችሁ successful ትሆናላችሁ እና we will make it a surprise የግድ ግን ይናገረን ከተባለ chief complaint ብንናገርም with that chief complaint we can go different direction እና I wouldn't really mind ልጅም እያለቀሰች ነው እና እዚህ ጋር እንጨርሳለን let's do that እና በጣም አመሰግናለሁ ወዳጆቼ ውድ ኢትዮጵያውያን ሐኪሞች ሰላም ሁኑልኝ ሌላ የተለየ ኮሜንት ሐሳብ ያለው ሰው አለ
Thank you doc በጣም the only thing ሁሌም መጨምረው YouTube ላይ ፖስት ይደረጋል
ኦኬ
ሪኮርዲንጉን ላክልን
እልካለሁ አሁኑኑ ሪከርድ አድርጌ ወዲያው ልክ ኮንቨርት አድርጎ ወደ እንትን እንደጨረሰ አስረክባለሁ ጌታዬ እቺ ጩጫዋ መጨረሻ በር ገንጥላ ልትገባ እየታገለች ያለች
ናምበልልኝ እንግዲህ
እሺ አይተኝታ እየተነሳች መሰለኝ አክቹአሊ ሌላ ሩም ውስጥ ነበር የነበረችው ቅድም የተነሳሁትን በር ለማቆለፍ ነው አክቹአሊ ድንገት ሰንበሪ ብዙ ሰላም ሁኑ በቃ አትጥፉ እሺ ባይ ባይ ይሄን ዊክ ስራ ነኝ ከዛ ደግሞ ኔክስት ማክሰኞ ነበር አይደል ፕላናችን ኔክስት ፕላን ደግሞ ወደ ቨርጂኒያ መሄድበት ጉዳይ አለኝ እዚህ ደግሞ ቤቱን ለቆ ሄዷል ብላችሁ ለዘረፋ እንደትመጡ ሰው ይኖራል ካልደ ነው maybe next weekም ላልችል እችላለሁ ግን I will let you know in case if I can do it ከሄድኩበት ቦታ ሰኞና ማክሰኞ ላይሆን ይችላል one of the days next week ሞክራለሁ ማልችል ከሆነ ግን እዛ ሄጄ fully engage የሚያደርገኝ ከሆነና ማልችል ከሆነ so for the next week ላይኖረን ይችላል another session ማለት ነው እሺ እግዚአብሔር ያውቃል ግን እንግዲህ for 2 weeks ላይኖረን ይችል ይሆናል for that reason ግን we will see ወይ ታይሙን ፑሽ አድርገን ምን ብለን ዊኬንድም ቢሆን ኮምፐንሴት ለማድረግ እንሞክራለን ወሌላ ሰው ማግኘት ከቻልኩም አትሊስት እኔ ፉሊ ኢንጌጅ አድርጌ መስጠት ባልችልም ሌላ ሰው ራን እንዲያደርገው አደርጋለሁ we'll do something okay
እሺ ዶክ
ለዛሬ ግን አሳይመንት አለ ባይዘ all of you should be reading about NIHA classification New York Heart Association classification የheart failure አይነቶች ምናምን አሉ ማጥናት ያለባችሁ which we didn't discuss ማለት ነው ይቺ ፔሸንታችን NIHA ክላስ ስንት ናት እስቲ በግምት ኧረ ተው እንጂ ነው
አዎ ዶክ እኔም እንደዛ ልገምት ነበር
የሰማሁት ነገር የለም የሆነ ሰብኦርዲናሪ አክቲቪቲስ ላይ ላይክ ሙቪ
እንዴ ተቀምጬ ምንም መስራላም እያለች ሽንት ቤት መሄድ ራሱ አልቻልኩም ምንም አይነት አክቲቪቲ without distress አልችልም እያለች ኢቭን
ኦኬ አትሊስት አይ ቲንክ በደንብ አልሰማሁም እኔ ፕሮሚነንት ላይ የተቀመጠው ሽንት ቤት ድረስ ለመሄድ ያስቸግረኛል
አይደለም እንዴ እሱም አንደኛ ምን ያ ኢቭን እኮ ትንንሽ አክቲቪቲ መስራት ኢቭን ባዝሩም እኮ 10 ስቴፕስ አይሆንም ማለች እኮ ያ የሚነግርህ ኢቭን ስላይተስት ኤክሰርሳይዝ እንደሚከብዳት ነው ከእንደገና ደግሞ ኢቭን አትሬስት ዲስኮምፎርት አላት ሶ ክላስ 4 ነው ክላሲፊኬሽኑን በደንብ አጥኑ then you'll understand why we are classifying her as class 4 ሌላም ደግሞ አለ አይደለ ABCD የሚባልም ክላሲፊኬሽን አለ with structural heart disease without structural heart disease ምናምን እንደሱም አይነት ክላስ አለ ከኤ እስከ ዲ የትኛው ጋር ናት ከኒሃ ክላስ ስንት ናት የሚለውን እሱን እንትን ትላላችሁ ፈርዘር ከጠየቋችሁን ብትመልሱ በተረፈ በርቱልኝ አትጥፉ if you have any questions you can always reach out to me ቲክቶክ ገጽን ማትከታተሉ ሰዎች የቲክቶክ ፔጅን ላይክ አድርጉ እዛ ላይ ራሱ በ3 ደቂቃ በአማርኛ ብዙ ዲዚዝ ነው ማወራው ሰመራይዝድ የሆነ ለፔሸንት እንዴት ብላችሁ ኮሙኒኬት እንደምታደርጉ ምናምን አይዲያ ታገኙበታላችሁ ዩቲዩብ ገጽንም ተከታተሉ ላይቭ ሰዎች ኢንተርቪው አደርጋለሁ እንደዛ ሳደርግም አልፎ አልፎ ስሙ ሊንክድኢን ላይ you can be my friend ፈቃደ ስላሴ ሄኖክ ሞገስ ነው የሚለው ቲክቶክ Dr.FSH ቆይ የቲክቶክ ገጽ Dr.FSH እና በአማርኛ ዶክተር ፈቃደ ስላሴ የሚል አለው እንደዚህ ነው ብትፈልጉት ታገኙታላችሁ ዩቲዩብም ይሄው ነው የዩቲዩብ ገጽ እና ሰብስክራይብ አድርጉና ፎሎ አድርጉ በተረፈ እግዚአብሔር ከሁላችንም ጋር ይሁን። ሰላም ሁኑ። እሺ ባይ ባይ። ዜክስ አትጥፋ፣ እልክልሃለሁ ሪከርዲንጉ።
እሺ ዶክ፣ መልካም እንግዲህ መልካም ጆርኒ ወደ
እሺ ሰላም። ኧረ ስራውን መልካም ስራ በለኝ እንጂ 7 ቀን ስራ ፊት ለፊት ቁጭ ብሎ። ባይ ባይ።